Good afternoon, ladies and gentlemen. Welcome you to the National Clinical Care Commission. I am Dr. Clydette Powell, Medical Officer for the National Clinical Care Commission. We'll start our meeting with a roll call. Dr. William Herman.
Present.
Dr. Ann Albright.
Present.
Dr. Howard Tracer.
I'm here.
Dr. Barry Moss.
Present.
Dr. Naomi Fukagawa.
Present.
Dr. Bell.
Present.
Dr. William Chong.
Present.
Dr. Aaron Lopata.
Present.
Dr. Ann Bullock has an excused absence due to family medical. Dr. Barbara Linder.
Present.
Captain Samuel Wu, also excused absence. Dr. Paul Conlon.
Here.
Dr. Ayotunji Doku.
Present.
Dr. Carol Greenlee.
Present.
Dr. David Strogat.
Present.
Dr. Dean Schillinger.
Present.
Ellen Leake. Ellen Leake. Dr. Jasmine Gonzalvo.
Present.
Dr. John Boltry.
Present.
Dr. Meredith Hawkins.
Present.
Dr. Shannon Idzik.
Present.
Dr. Sherry Boland.
Here.
Dr. William Cook.
Here.
Thank you. This ends the roll. I announce that there is a quorum, and I'll pass this over to our chair, Dr. William Herman.
Great. Thank you very much, Clydette. I too want to welcome you to this 9th meeting of the National Clinical Care Commission. If I can have the next slide, please. I just want to remind you all that the National Clinical Care Commission is a federal advisory committee established by the Secretary of Health and Human Services to evaluate and make recommendations regarding improvements to the coordination and leveraging of programs within the department and other federal agencies related to awareness and clinical care for diabetes. Next slide. The Commission is charged with evaluating and making recommendations to the Secretary and Congress regarding federal programs that focus on preventing and reducing the incidence of diabetes, current activities and gaps in providing integrated high-quality care, the improvement in and improved coordination of federal education and awareness activities, which may include the utilization of new and existing technologies. Next slide. Methods for outreach and dissemination of education and awareness materials for healthcare professionals and the public, and opportunities for consolidation of inappropriately overlapping or duplicative federal programs. Next slide. The work of the National Clinical Care Commission is being performed by its subcommittees and these are focused on the treatment and complications of diabetes, prevention of diabetes in a targeted high-risk population, and prevention of diabetes in the general population. There's also a work group that's focusing on access to care and promising models for integrated service delivery and payment. And within each of these subcommittees, there are a number of focus areas, including social determinants of health, health equity, and research needs. Today, our agenda will focus on new draft recommendations from the subcommittees, and we'll also be hearing brief comments from 9 members of the public. So at this point, I'd like to turn the podium over to our first subcommittee, which is focused on treatment and complications, and this update will be provided by Paul Conlon and Carol Greenlee. So if I can have the next slide, please.
Dr. Herman,
Yes.
you'll be introducing Dr. Fink.
Oh, all right, excuse me. Yeah, I'm very sorry. So we do have a new program officer who is Dr. Dorothy Fink from the Office of Women's Health, and I'd like to briefly introduce her and have her say a few words as well. Sorry, Dr. Fink.
Oh, well, thank you, Dr. Herman. I really appreciate the opportunity to join you and the National Clinical Care Commission, as well as members of the public who are attending today. The Office on Women's Health has the new honor and privilege of providing support to the Commission in its 3rd and final year of work. We are well positioned to seamlessly transition administrative support for the Commission from our sister office within HHS, the Office of Disease Prevention and Health Promotion. The Commission's work to provide recommendations for coordinating and leveraging federal programs to improve diabetes care really does synergize with our office's efforts to promote the health of women across America. Diabetes impacts women across the lifespan, whether directly as persons who have diabetes or as expectant mothers who may have gestational diabetes, or those who care for family members who are affected by diabetes. As the Deputy Assistant Secretary for Women's Health and as an endocrinologist, I understand firsthand the challenges faced by healthcare professionals and everyone in public health as they partner with the public to prevent diabetes in the general population, target and work with anyone at risk for prediabetes, as well as treating and caring for patients with diabetes complications. We really look forward to the Commission's 3 subcommittees that focus on these topics today. We are so grateful for the dedication of the distinguished Commission members who are providing expertise during the Commission's 3-year lifespan and really look forward to working with the committee as we develop this report. I look forward to today's discussions about the committee's 2nd round of draft recommendations. Thank you all for your time today, and we really look forward to the public comment section as well. I will turn the meeting over to Dr. Herman.
Great. Thank you very much, Dr. Fink, and we really appreciate your participation and support. I will now turn the meeting over to the first subcommittee report on treatment and complications, which is chaired by Paul Conlon from the VA and Carol Greenlee. So, Paul, Carol.
Thank you, Dr. Herman. I'm Carol Greenlee. I'm a special governmental employee, and Paul joins me in co-chairing. Somebody moved our slides. Sorry about that. Our subcommittee also is made up of several other members, including those who are special government employees or non-federal members, Dr. Sherry Bolin, Dr. Ayatunde Doken, Dr. Jasmine Gonzalvo, Dr. Meredith Hawkins, Dr. Bill Herman, and Ellen Leake, as well as 2 additional government employees, Dr. William Chong and Dr. Barbara Linder. Whoops, sorry about that. today we're going to kind of share with you our committee, our subcommittee focus and our workflow. We have some draft recommendations that were made in September that we've been quote unquote maturing, and then we've been more, we've revised and developed new draft recommendations, and we'll go over those. Just to recap, we have opted to focus our efforts under treatment and complications on closing the gap between resources that are already available and the patients. Based on all the resources that are available, we should be doing better with people with diabetes than, or the people with diabetes, I should say, should be doing better than they are. So we want to focus our work on where we can move the needle the most, where we'll have the biggest impact, and where those efforts are supported by evidence. So we are prioritizing recommendations around diabetes self-management, education, and support, team-based care, diabetes technology, and virtual care. And we've divided our subcommittee into small work groups to focus on each of these areas. And running through all of our small group work is the topic of health equity, reduction in health disparities, and optimization of individualized care. That brings us to our first maturing draft recommendation, which is on health equity. And we recommend that the federal agencies consider health equity as a component of any new or revised policy related to diabetes, meaning that for any new or revised policy related to diabetes, the relevant federal agency will consider and evaluate the impact on health disparities. They will ensure the collection of appropriate and relevant data and will use such data to assess and improve the impact of their policies and or regulations on health disparities among people with diabetes. I'll now hand off to my co-chair, Dr. Paul Conlon, to moderate our draft recommendation presentations. Paul?
Great, thank you, Carol. I appreciate Dr. Greenlee's leadership with this on this subcommittee. It's my pleasure to introduce Dr. Jasmine Gonzalvo, who has been leading the subgroup related to diabetes education and support, and she'll give us a report on past as well as current activities of that subgroup.
Thanks, Paul. With regard to the work that we've done since the last full commission meeting, we had an additional stakeholder call on September 18th with the Association for Diabetes Care and Education Specialists and the American Diabetes Association, where we reviewed these draft recommendations, and we have also since then received additional written comments from ADCES. Our draft recommendations presented at the last full commission meeting remain unchanged and are presented here on this slide, with the overall goal to expand access and reduce barriers to delivery of DSMT, as well as reducing administrative burden regarding standards and documentation requirements for DSMES programs. We recommend to create a task force with the authority to update the Medicare quality standards that govern DSMT and establish a process for ongoing timely review, updating, and revision with input from external stakeholders. Also, to develop processes to utilize Quality Innovation Network, Quality Improvement Organization data to generate CMS policies that support community-based diabetes education programs, as well as prioritize funding for innovative research to explore factors that affect referrals to and patient uptake of DSMES, such as patient, clinician, and systemic level barriers, quality measures and incentives, and patient-reported outcomes and perspectives. We've also begun to draft our report, which will outline additional details supporting these recommendations.
So what we're going to do through the course of this subcommittee presentation, actually if we could go back one slide please, is that we're going to pause after each of the subgroup leads present and invite comments or questions from commission members. And in that way, we'll be able to have more rich discussion around the specific draft recommendations or work in progress, rather than waiting till the end and having a more global discussion, which if time does allow, we will have the opportunity to do. So we'll pause there and open up to anyone's comments or questions about our draft recommendations with regard to diabetes self-management and support. So I'm not currently hearing any questions. That either means there are none or people don't have the opportunity to unmute their phone. We will have other time as necessary if people want to pose questions. What I will then do is we'll advance one slide, and I will introduce our next subgroup lead, Dr. William Chung, who will present on the work of his subgroup that is focusing on diabetes technology. Dr. Chung.
Thanks, Paul. So I'm going to see if I can figure out how to advance the slides while talking. So similar to Jasmine, I'm going to be providing a brief update on where we have been trying to refine and revise our recommendations as presented last time. As a brief background, we're focusing on diabetes technology on the premise that improving access to innovative diabetes technologies such as insulin loops, continuous glucose monitors, some of the new closed-loop insulin delivery devices, that having access to these can improve the quality of life and clinical care of patients with diabetes, and really trying to focus in on some key areas that we've heard from stakeholders and public comments on being able to keep pace with the new and evolving technology and data, as well as trying to reduce burden on patients and providers. So in the interim since the last commission meeting, we've had some additional stakeholder calls. I'm showing them here. We've had a call with Dr. William Cephalou from NIH's National Institute of Diabetes and Digestive, NIDDK, sorry, it's a bit of a mouthful. Had a call with Dr. David Klonoff from the Diabetes Technology Society, Dr. Robert Lash from the Endocrine Society, and with representatives of the Juvenile Diabetes Research Foundation. And the efforts here were really try to further refine our recommendations, get input on additional areas that we may want to consider. So turning to the recommendations that we had presented last time, we've refined and revised them just a little bit since then. And I'm going to read through them here, focusing on some of the initial ones, which we think may have more of an immediate short-term impact. And then as we move through them, things that might have a little bit of a longer-lasting benefit for patients with diabetes. So one of the first recommendation here is that we would recommend that there's continuation to allow for virtual visits in order to minimize disruptions of care and reduce unnecessary patient burden. We'll hear a little bit more about virtual care from Ellen later, but this is for purposes of diabetes technology. We think that this is something that will have it could have an immediate benefit in terms of improving access and reducing barriers. The next recommendation is slightly refined from last time, and the piece here I would like to focus on in terms of refinement is a recommendation to update the current requirements for different diabetes technologies and to establish a process for regular reevaluation of eligibility requirements. Something we've heard with a lot of the stakeholders is that the current requirements need to be updated I believe on our last meeting, we really were focusing on establishing a regular process for reevaluation, and wanted to add the piece here about sort of addressing in the more immediate future sort of the current requirements. And then the last recommendation was we were working on it, refine the language a little bit, but essentially is to establish a process to ensure clarity and consistent application of eligibility and reimbursement requirements across all parties involved, including Medicare administrative contractors and auditors. And this was a recommendation that we had generated in response to some comments we heard where there appeared to be different expectations across the coverage environment. So that's where we stand in terms of the diabetes technology subgroup, and I'll pause here, see if there are any questions, comments before turning it back to Paul.
Yeah, thank you, Bill. So please, if anyone on the commission would like to ask questions about this topic, please I'm reminding you to unmute your phones. Okay, not hearing any additional questions, we'll move forward. May I have the next slide, please, Joanna? The next subgroup report from our subcommittee will be on the topic area team-based care, which will be presented by Dr. Sherry Boland. Sherry?
Hi, thanks. So, in general, just we've initially talked about community health workers at our last call when we met at the last committee meeting, and this is as we've met with a number of stakeholders, we've really thought more broadly in team-based care as we've looked at pharmacists and integrated behavioral health. So this is really going to be different than the recommendations we made last time, as this has been an evolving area as we've met with stakeholders. So just as a sort of a reminder that team-based care addresses barriers to optimize individualized diabetes care and outcomes, and in particular focusing on some areas that are high priority that can really make an impact on people living with diabetes and their outcomes. And so unmet social factors is one area that we've looked at, and behavioral health issues is another. Looking at trust and effective communication between healthcare teams and patients, and then looking at addressing complexity and polypharmacy. And so some of the big areas that really get addressed when you have good team-based care. And some of the key barriers that have come up in terms of implementation of team-based care have been around sort of three buckets. One is the healthcare workforce shortages, especially in disadvantaged and rural settings. The second is around reimbursement for team-based care, especially reimbursement around integrating community health workers, pharmacists, behavioral health, and thinking about coordination among specialists in primary care. And the third is really around technical assistance and the need to have some implementation support and strategies to help put this into practice. And these were the additional stakeholder calls that we've had since the last committee call. And they've been, I won't go through each and every one, but it just, you can see the number of different people that we've spoken to, both folks within Medicaid as well as professional organizations, as well as folks who do research around community health workers, HRSA, and some policy areas as well. So for the clinician workforce, just the background that we heard both through documentation as well as stakeholder calls was that we know that about $12 billion are spent on workforce training, primarily focused on graduate medical education by three main groups, CMS, the VA, and DOD.
and that CMS GME payments are the primary source. It's about $10 billion that go to teaching hospitals. And those teaching hospitals have caps on the numbers of trainees that they can have to receive specific payments. And then when we met with HRSA, we found that they assess and assist with workforce training, although the amount and dollars for HRSA is quite limited compared to the other organizations, somewhere around $600 million, if I'm remembering correctly. And there's limitations on who can get trained under specific opportunities. And last, there's a need for, we found that from several government reports, there's a need for a global assessment of healthcare workforce needs. There's specific committees on physicians, for instance, and then on a couple other groups, but not really this global assessment of healthcare workforce needs. And then there was really found to be a lack of standardized, coordinated data collection efforts so that we can show the impact of the training on workforce needs so that we can see if we're addressing those needs. And we found that the agencies that were providing the training programs were typically not aligned with the HRSA reported workforce needs, and HRSA does a number of those reports as well. Although, again, I think this global assessment of healthcare workforce is really needed for us to address that. So Congress actually established the National Healthcare Workforce Commission under Section 5101 of the Affordable Care Act, and that was done to provide data on the healthcare workforce and policy advice to Congress and the administration, but it was not funded at that time. That Workforce Commission was really charged with 5 general bullets, communicating and coordinating with different governmental agencies over workforce policies, developing and commissioning evaluations of workforce education and training programs, identifying barriers to improve coordination of federal, state, and local workforce policies, encouraging workforce innovations to address population health needs, and producing, they were asked to produce 2 reports annually on key workforce issues. So we're under development of what our recommendation will be here. Currently, we're thinking of saying that the National Healthcare Workforce Commission or a similar committee should be funded to assess these global healthcare workforce needs. And then relevant government agencies really need to act in a coordinated and aligned way to meet those needs, as well as measure the impact to make sure we're actually addressing the workforce needs. And such a recommendation, around the National Healthcare Workforce Commission has been proposed in the past, as you just saw. There wasn't action on it, which made us concerned about the political will to sort of bring that about. So we're also looking at several additional smaller steps that we may be able to recommend to achieve some of our goals or some of the stated goals through other mechanisms. So we're still under investigation around some of those. In the second bullet that I mentioned in terms of key barriers was reimbursement. So we're really had several meetings with almost all of our stakeholders have suggested incorporating use of community health workers, pharmacists, and integrated or collaborative behavioral health into existing Medicare and Medicaid value-based payment models through incentives. And those incentives could be additional incentives for incorporating use of team members or just not fully accrued without use of them. And then we've heard that incentives are needed at the provider and team level as well as the system level. So those are some things that we've heard and we're thinking about as we think about how to draft those recommendations. And the last bullet was really around technical assistance. So most stakeholders mentioned the need for expert consultation on how to integrate team members into care. 2 suggestions that were made were recently were around funding the primary care extension programs, which were listed in also in the Accountable Care Act, Section 5405. So we're looking at that. The second suggestion was around allowing flexibility for primary care practices to hire consultants to provide expert consultation. So some of our next steps, as I mentioned, is really to just determine any additional recommendations and refinements for clinical workforce. We're looking at trying to talk more with folks around HRSA through the Title 7-8 funding, if there's opportunities there. Looking at team-based care reimbursement a little bit further around refining that, and looking at continuing to investigate some avenues for technical assistance to ensure alignment across agencies without duplication of effort. With that,
why don't we go back one slide, please?
Yeah.
So we'll pause now and be happy to take any questions from commission members about what Sherry's discussed with regard to team-based care and the work under develop, or the draft recommendations that are still under development. I remind people to unmute your microphone, or alternatively, I was reminded that there is a Q&A box in the Adobe Connect platform that people can actually type comments or questions as well.
Yeah, hi, Paul. This is Dean Schellinger. If I may address Sherry.
Absolutely, please do.
Yeah, thank you, Sherry. Very exciting to see this work. I wanted to ask you a little bit more about where you think the subcommittee is going in terms of the workforce issues. I was very grateful to see that you guys have focused on the workforce issues, which are so clearly needed in terms of diabetes care, both from a primary care perspective as well as certain subspecialties, podiatry, et cetera. You appropriately pointed out the sort of limitations that we have faced as a country in the past in terms of measurement of the problem. Yet, those of us in the field are pretty well aware of how vast the gap there is between the capacity that we currently have to deliver care for people with diabetes based on the need. Do you anticipate that the subcommittee is going to make recommendations regarding increasing the primary care and related workforce needed to fill the need?
Yeah, I mean, I think that's an interesting question. I think that there's clearly areas of need, and you can see that through the HRSA reports as well. I think I don't know if we're going to get to that level of detail because, truthfully, I think if we want to really meet the needs of the healthcare, and this is my opinion and not those of the subcommittee, so anybody could say something different. But I think, we don't really have a good sense of how we can fully address all the healthcare workforce needs beyond just physician level. So we know that there's a need, but we also have these other team-based care members that could support those needs. And we don't really have any assessment of some of those different groups and what we need to really get there so we have penetration across the U.S., in my opinion. So, I mean, personally, I think that we were looking more at trying to fund that committee, which, sort of primary care workforce is a big piece of that. So I don't know, Dean, if that gets at what you're trying to say or not.
Well, yeah, maybe I could be more concrete. So, for example, with respect to the primary care workforce, HRSA has had a program in the past that has funded training programs, residency programs, to essentially produce highly skilled primary care physicians. And these are grants, and they're highly competitive. And so you may get 300 applications and 5 programs are funded. And those are great programs, and they'll put out 25 new primary care physicians who will go into primary care in underserved settings. But even there, the demand for training and the thirst for doing this far outstrips the degree to which the incentives are put out there for the medical community to kind of be able to do the right thing. So things like that, where there are existing programs that seem to work very well but need to be scaled up,
Yeah, thank you. Thank you. Yeah, we are looking at sort of what we can, in particular with HRSA, and I think we had reached out actually to Dr. Wakefield on, after hearing from Dr. Grumbach, but so whether, she's quite busy with the Biden work that she's doing right now, so I don't know, we're hoping to sort of meet up with her maybe in January based on her schedule. But we may look into other people we can speak with, and that is one area within HRSA that I think there's some opportunities to make specific recommendations separate from the actual workforce commission. And so that's where we're looking to spend some effort in the next few months before February. I don't know if that helps answer that, but that's where I see that falling.
Yeah, that's terrific. Thank you.
And this is Carol. I'll just jump in to say that we fully recognize a disconnect between the needs assessment and where the funding goes for GME, that the funding, what trainees are funded is determined at the academic medical center, and it's often based on what they get, what they can bill more for, as opposed to what the needs in the community or the needs in the country are. And so I think somewhere in our hope is that if there was this National Workforce Committee funded, that there would also be some authority to increase accountability around meeting the needs of the population, and not just what the academic medical center can bill more for. Our discouragement there is that not only was this part of the ACA, but in the past 10 years, many organizations have recommended for funding of this National Workforce Committee, and over the 10 years, it has never been funded. And so in addition to recommending that, I think we can recommend more accountability on meeting the needs, and then we're still in process on what, in the meantime, what steps can be taken to meet those needs. And that's why we say our draft recommendations are under development, because we're still trying to figure all that out. But thank you for asking.
Yeah, no, absolutely. Yeah, and we are, in our subcommittee, we're grappling with the same issue as you know, Carol, which is, okay, there's a recommendation that we're thinking about, but how do we make it very specific, right? And it's very hard to do.
Yeah. Thank you.
And Dean, Paul Conlon here. I think this is an example of when we finally propose a recommendation, it is likely going to be cross-cutting and will benefit from the input of your subcommittee and the other subcommittee as well, because it clearly intersects the entire work of the commission, not unique to the treatment and complications subcommittee.
Yeah, this is Don Shell. I had a follow-on thought about, Dean, the comments you brought up, and thinking about what is the evidence of the outcomes of the effectiveness of those training programs that, I guess, prepared those primary care docs to go out in settings to provide care. Are you aware of any metrics that were used to determine their impact on overall health outcomes, or any metrics about the effectiveness, and can kind of look at the cost of it or the health outcomes as far as the impact of that training on those providers? Thank you.
I don't know if you want me to answer that. Maybe Dean can comment further. When we met with, and HRSA could comment further, or other people, when we met with HRSA, I believe when we were talking a little bit about this, some of the, because these are not specific to a particular condition, and we could look further into sort of what they might have on a particular condition. A lot of these were really measuring sort of, did people stay in disadvantaged or rural areas where there was a need, and so there's been a lot of success shown in those HRSA grants around where people train. Is, I think, around 50% stay in that area. So I think that was one real success in terms of just meeting the needs of the population in those areas. But others can comment on health outcomes. I don't recall us having that part of the discussion.
Yeah, this is Dean, I would agree that HRSA's metric, and they follow this extremely closely, and each program is required to track the location of their graduates' practice for often many decades over time. But the HRSA relies on the prior research that had shown that access to care in medically underserved areas is the strongest predictor of preventable hospitalization rates. So the greater the access to care, the fewer the preventable hospitalizations. So they don't track changes in preventable hospitalization rates by region because they don't have control over where those graduates end up practicing. But the fact that they are practicing disproportionately in underserved areas would make one infer that preventable hospitalization rates should go down.
Okay. Yeah, thanks. I was just thinking about arguments to continue that funding and maybe enhance it. So I appreciate that.
Yeah, this is Paul Conlon again. One of the things that Dr. Greenlee mentioned, and I think everyone is aware of, is that the largest funder of graduate medical education is CMS through its reimbursement to primarily academic health centers. And the biggest concern is that there's little accountability as to how they allocate training positions to whether it be primary care or to subspecialties. The funding that's allocated to HRSA, which, as we heard, might actually be impactful, is actually a very small fraction of the overall budget that the federal government has allocated to graduate medical education. So we see that changes are going to be needed globally, not just with regard to, say, a specific program that is funded by HRSA. Are there other comments or questions about this subgroup's report? Okay, why don't we move on to the next subgroup report, if we could have the next slide, Joanna. And this subgroup is focused on virtual care, and Ms. Ellen Leak is the lead, and she'll give us a presentation with some support also from Dr. Carol Greenlee, who also is a member of that subgroup. Ellen?
Thank you. We had a great subcommittee meeting last week. And just a couple of words of overview. What do you call this virtual care, telemedicine, telehealth, digital health care? The list of descriptors goes on. But we're really referring to a broad umbrella using telecommunications and information technology to provide access to health assessments, diagnosis, interventions, monitoring, supervision, and information across distance. Whether we agree on the terms of the definitions, one thing is for sure. Technology is changing at such a rapid pace that really static definitions can't even keep pace. On our stakeholder call with HRSA a couple weeks ago, they made the point that COVID in the past 8 months has really been the accelerant that has propelled the use of virtual health care, not by 8 months, but perhaps by 8 years. So this morning in this section on virtual care, we'll spend most of our time talking about recommendations for building capacity and streamlining processes to deliver virtual care. So Joanna, if we could go to the next slide to look at our informant interviews. As I said, we had a great call with HRSA mid-October. Then a few weeks later, Bob Lash at the Endocrine Society, and most recently, Project Echo, and more about that in just a few minutes. So if we could move to the next slide and begin talking about the VA-DoD Virtual Medical Center. The background on this was in 2019 and a joint effort between the VA and DoD and a grant. They created this great national virtual information technology platform. CMS calls it a facility without walls, but it serves vets and active DOD and their families. And it uses novel technology to deliver virtual care and education when distance and convenience and even a pandemic precludes providers and patients for being face-to-face. And I thought rather than talking through this, it really came alive for me when I watched about a 4-minute video. We thought we'd break up the PowerPoint presentations by showing you just this short clip that will give you a better sense of a virtual medical center. So Joanna, if you could roll the video, that would be great. Hi, I'm one of many VA and DOT diabetes care and education specialists who provide diabetes self-management education training here in the VA Virtual Medical Center, or VA VMC, to our beneficiaries. The VMC is available to all veterans, active duty, and their family members. If you have a computer or laptop, you can register at vavmc.com. Then your avatar can roam the VMC and access information 24/7 about many disease processes, as well as meet with your provider or healthcare team. You can also meet with your peers for fun or support. All of this without leaving your home. Let's teleport to the diabetes clinic. Click on the map icon on the blue bar and select Diabetes Clinic. Welcome to the new virtual world of the Diabetes Clinic. This is where you will come to find your education session or other event happening in the VMC. You can click to accept an event, and when it's time for the event to start, you can click to enter the room. These events are hosted by real providers, such as myself, who teach diabetes self-management classes to real patients. Class time is used to highlight important points and encourage discussion about all the participants' experiences managing diabetes and setting goals for better management. Virtual PowerPoints are used, as well as easy communication to everyone in the class with a push of a button. And don't worry, these classes are private to only those who attend. You will need a referral from your provider to participate in the group diabetes self-management training session. Let me show you where to find the materials for class. Throughout the VMC, you will find posters that you can click on and view informational documents or videos. This is where to find the interactive participant handbook for the group diabetes education classes. You can click and view or download and print the documents if you like. You will find information and activities for each module. There are 8 modules or group classes. We use a flipped classroom approach, where a participant reviews the materials before coming to class. To find more information about diabetes, there are a couple of other resources here in the Diabetes Clinic. Isn't this awesome? Let's show you other great areas here in the Diabetes Center. This is the Education Center, the Fitness Center, the Nutrition Center, and Heroes Beach. There are several cabanas with videos on different health topics. Cabana 1 and 2 have information on both type 1 and type 2 diabetes. If you're ready to start exploring, go to vavmc.com to register today
ask your provider for a referral if you would like to attend the Group Diabetes Self-Management Education Training to get the full virtual experience.
Thank you, Joanna. Great. Let's move to the next slide. So the problem that we're trying to address here would be the common barrier to completion of DSMEF and a certified program, especially in remote and rural locations, which can mean long travel times and certainly daytime class attendance can conflict with work schedules. So the recommendation would be to provide funding to design and implement a pilot program that leverages the virtual medical center to increase access to DSMEF and DSMT for beneficiaries for beneficiaries and people living with diabetes and other federal health programs. Moving now to e-consultations, and I may call on Carol toward the end of the presentation to add here to the content. But the background, e-consultations, which are just virtual clinician to clinician consultations, offer an opportunity to get needed specialty care for people with diabetes. And you can see the benefits there, less delay, a mechanism to transfer new evidence into practice, less patient burden. So I would state the problem as confusion and burden to practices and patients around coding and billing, and they often discourage really the use of e-consults as well as threatening program integrity. So the recommendation, if we can move to the next slide, we would like CMS to take the following steps to increase program integrity and certainly the utilization of these interprofessional consultations. Number one, require that billing code 99452 be submitted only after treating providers act on recommendations from a consultant. Number two, clarify the language within CPT descriptor codes for billing in 99451 and 2 that indicates treating providers should not use the codes if a transfer of care or other face-to-face service is generated by an e-consultant. Clarify that 7 and 14-day limits on single-use codes 99451 and 52 should apply per patient, per specialty. And finally, pursue pathways to waive coinsurance requirements for billing codes 99451 and 2 to reduce complexity and incentivize use of e-consultations. I think probably we'll just hold Carol's comments maybe into the Q&A section and move right into next slide, please, Joanna. Project ECHO. ECHO, as you probably all know, is the acronym for Extension of Community Health Outcomes. It's an old program started in the early 2000s, I think 2002, around hepatitis. And the objective here is to improve outcomes. In Endo-ECHO, improve outcomes of people living with diabetes, to reduce disparities, to address shortages of endocrinologists and other specialists, and to provide provider tools and more confidence to manage complex diabetes in patients. So Project ECHO is not telemedicine in which specialists assume the care of the patient, but instead it's a telementoring program
and it gives local providers that knowledge and self-efficacy to better care for their own patients in the communities where they live. The problem has been fragmented funding, and thus a patchwork limits the reach and sustainability, and thus the benefit of these programs. Next slide. Very much like Sherry's presentation, we have work under development, certainly. And Project ECHO has had several pieces of legislation introduced in the last year. Unfortunately, with all the work around COVID, that legislation has not come up for a vote. But we would like to identify sustainable funding mechanisms, perhaps through HRSA grants, to advance the use of technology-enabled collaborative learning and capacity buildings like Project ECHO. So let's move to the next slide, and I'll give you an idea of what's coming up. Telehealth waivers. We're very much in a wait-and-see mode. We think sometime after the first of the year, we'll know whether these telehealth waivers will be continued or not. But you can see there the array that really affect certainly virtual care, telehealth. And then the last slide, which is around our next step. We have not gotten very far into, as Carol said, we want to make sure any recommendations in virtual care do not exacerbate what I would call the digital divide. We are very focused on further discussions with the FCC. They have a powerful tool called Mapping Broadband Health in America. And it's in a model that would give us a better understanding of where the infrastructure gaps lie and where poor health outcomes intersect with infrastructure gaps. It's also a relationship between, we think, between broadband connectivity and diabetes health outcomes. But we have more work to do, much more work in that arena. And before our commission meeting in February, we expect to come back to you with a series of recommendations, both around waivers, and extension thereof, and around the digital divide. So let me pause there, see if Carol wants to add anything on e-consultation. She lives this every day in her practice, so it might be more appropriate to hear from her on that.
I think since we only have limited time left for questions, I think if there are questions, then I'm happy to clarify any of the very specific recommendations we have under that. I think you did a great job.
Yeah, and this is Paul Conlon, indeed. Thank you, Ellen. Why don't we take the last few moments to open up for questions from commission members about the subgroup focused on virtual care. But if there are some residual questions from the earlier subgroup presentations, this is an opportune time to present those as well. And reminding people, unmute yourself in order to ask your question, or if you like, you can type it into the Q&A box in the Adobe Connect platform.
So hello, this is John Boltry. Thank you, Ellen, for that presentation. I appreciate it and fully support the ECHO piece. We're doing a lot of ECHO at NeoMed, and I can attest to how much that helps private practitioners, especially primary care, that are working in rural areas. One question / comment about 99452. It's only 0.7 work RVUs, and it's about equivalent to a 99213 office visit. I'm concerned that if you make it only payable if a physician acts on a consultant's advice, there's a couple of issues there. One, I think it's actually going to discourage physicians from picking up the phone and calling their consultant. It's such a little amount that if you tie that to more paperwork and documentation, it's unlikely that that code will be used, which will, I think, in the end, decrease consultations. And it's just not that much. I mean, they're paying for essentially 16 or more minutes of work to encourage primary care docs to stop what they're doing either in between patients or a delay of seeing the next patient, or sometime later in the day when they're finished seeing patients to call a consultant for some help. Incidentally, the consultant can bill the same amount for just 5 minutes of work. So the consultant can bill a 451, which is also 0.7 RVUs, and for 5 minutes of work, whereas the primary care doc has to do at least 16 minutes for the same amount of work RVUs. So I would maybe look at wording that differently, maybe reimbursing the primary care doc more if they're able to document implementation of certain recommendations. I'll also say that when I call a consultant and they make recommendations, I almost always follow them unless for some reason I think their recommendation is not in the best interest of the patient. So I'm not sure that by requiring that you'll increase, but maybe Carol or others have different experience.
This is Carol. Our biggest external stakeholder for this has been AAMC, and they felt that recommendation would increase program integrity. They've been doing a pilot called Project Core with academic medical centers, and what they want to avoid is people billing that code when they initially send the consultation. Acting on it might mean, they don't want any more documentation, and I think we need to clarify that. What they just want is to be sure that the bill is sent in once the recommendation has been received. Acting on it could mean I don't agree with this, or there's nothing that needs to be done, or I'm going to start putting it in place. So we had a follow-up request for clarification on this particular thing because that concern came up among our subcommittee as well. So their intent was not to increase documentation. And I think just for clarification, requesting billing the patient for a copay when the average 20% copay is $5 to $6, it costs a lot more sometimes to bill that $5 to $6 than the $5 or $6. And then for specialty care, the patient has never seen the specialist, has never met the specialist, and so often the patient won't pay that bill, which then would require rebilling the patient and often not getting it. And so for both the primary care side and the specialty care side, that discourages them from doing e-consults. And the e-consults really dramatically reduce delay in care, open up access, reduce fragmentation by keeping the care with the primary care doctor, reduce the cost to the patient of taking time off work, parking, et cetera, et cetera. But the patients, when they hear that they're going to have 2 copays, say, well, I'll just go for a visit then. And now we have a jammed up specialty care clinic again, when this problem could be answered with a clinician-to-clinician virtual consult. And of course, their 20% would be much higher, but they don't understand that. And so that's why our recommendation to find some way to not have those copays. But we can absolutely work on the wording around that first recommendation. so that there's not an increased requirement for documentation. We had the same concerns, John, in our subgroup.
Yeah, and I totally agree with you to waive the copay. I'm just concerned that if you require, if you have an only after, then the burden's going to go on the primary care, the referring physician, to document that those have been acted on, and that's going to add more paperwork to a fairly small reimbursement already, like you said. Thank you.
Thank you.
We welcome any other questions that people may have.
Ellen, this is Bill Herman. With respect to the ECHO program, you mentioned that legislation has been introduced but hasn't come up for a vote. What were the specific recommendations to expand the program, and do you endorse those recommendations that was in the legislation?
Yes, the bill was introduced in the House, never got to the Senate. We had a call last week with some of the administrators at Project ECHO. The by and large, and then also Lamar Alexander's health education, the health committee in the Senate had hearings on this as well, but the legislation never got to the point where it was in conference. But the long and the short of this answer is that it was about funding. And I think you'll see that in our recommendation that the funding is so fragmented that there needs to be some way long-term for sustainable funding. And certainly during COVID, the ECHO with 13 different institutions is almost a proof of concept on how valuable a national program could be. But so by and large, the legislation was around the sustainable funding.
This is Carol. I'll just jump in. The funding was to HRSA or for HRSA, not from HRSA. And then they had some CMS-related elements in there that we're still trying to clarify. I remember one of them is to make participation in ECHO provide credits for MIPS. That was one. And then trying to see how else CMS could promote the use of ECHO. But the one that we think not only HRSA, but probably Indian Health Service and others who patch together grants to support the ECHO, Project ECHO, or the ECHO format. If there was more funding, then that increases the capacity in the clinics to meet the patient's needs and probably provides a big return on investment. It's been a little hard to get the data on the return on investment for diabetes because most of the initial work was on hepatitis, but we're working on that. Did you have a suggestion?
No, I was just trying to understand where the recommendation for funding was, and I think, to have clear lines of authority and clear lines of funding would certainly facilitate it. I think HRSA or CMS or IHS would all make sense.
This is Naomi. I had placed it in the Q&A, but I guess it wasn't seen. And so this was for the first presentation in terms of the Workforce Commission. It appeared to me that the description of it aligned with the this commission's charge. So how would the subcommittee suggest melding it with the charge of this committee to reduce redundancy in federal agencies and programs?
Hi, this is Sherry. I understand what you're saying. It's sort of like we're in a commission now, and why do a separate commission? I think it is a pretty large scope to understand and assess the actual the global healthcare workforce needs. And so that really is an undertaking that sort of needs to happen at a larger level. I do think that we can make some, we might be able to make some specific recommendations, as we get further into discussing it within our working group. But I worry about our ability to really address this issue solely within this commission. But I'm certainly open to that conversation within our working group.
Thank you.
So Dr. Herman, we're a few minutes over our allotted time, but why don't I send the meeting back to you?
So I'll turn it over for the Targeted Population Subcommittee report.
Thank you, Bill. This is John Voltry. Just mention that Ann Albright is going to be stepping off as co-chair following this meeting. And Howard and I will remain as co-chairs. So good afternoon, everybody. We are going to move on to talk about the Prevention Targeted Population Subcommittee of the National Clinical Care Commission. And let me see if I can figure out how to advance this. Yes. So there are 5 special government employees on our subcommittee, including me, Bill Herman, Shannon Idzik, Ellen Leak, and David Strogatz. And there are 8 regular government employees on our committee, including Ann Albright, Naomi Fukagawa, Barbara Linder, Barry Marks, Pat Shoemaker, Don Schall, Howard Tracer, and Captain Samuel Wu. So the members of the Prevention Targeted Population Subcommittee have been meeting regularly since the last National Clinical Care Full Commission meeting. In addition, we have been receiving support from Claudette Powell, the Office of Women's Health, and Jennifer Gillison, and a number of other people. Thanks to all of you. The Prevention Targeted Population Subcommittee has been organized into 4 subgroups that each work on the 4 focus areas, developing recommendations that have been reviewed, edited, and approved by the entire Prevention Targeted Population Subcommittee. So the 4 focus areas of the Prevention Targeted Population Subcommittee are listed here. I'm not going to read those for you. We have completed 2 additional agency calls since the last full NCCC meeting, one with CDC and one with HRSA. And we have not conducted any additional stakeholder calls since the last full commission meeting, although we have completed those previously. I'd like to give a brief update on our literature search. We have 6 questions. The first one concerns rates of screening for prediabetes, referral rates, participation rates, and rates of medication prescription. The second is concerning current knowledge of lifestyle prevention programs for prediabetes, including effectiveness of various programs, completion rates, outcomes, and costs. The third question is concerning successful strategies for getting people to participate in DPPs and complete DPPs. The fourth question regards current knowledge of medications for prediabetes. This is different from looking at rates of medications prescribed for prediabetes. The fifth question is knowledge about maintaining positive lifestyle change acquired during diabetes prevention programs. And since the last National Clinical Care meeting, we've added an additional question 6 to our search, which involves effectiveness and risks of surgical methods for type 2 diabetes prevention. Currently, we have received the results of 3 of the search questions, and our team is working on the results and anticipating the next set of results. At this time, we are going to have one of the leaders of each of the 4 subgroups present the background, problem, and recommendations from each subgroup. At this point, I would like to introduce Dr. David Strogatz, who will present the Prevention Targeted Population Focus Area 1 progress and our draft recommendations.
Thank you, John. I'll be reporting on the first focus area, screening diagnosis for prediabetes and diabetes on behalf of the subgroup that's shown here. Our first recommendation, raising public awareness about prediabetes in the NDPP, builds on collaboration between the CDC and the Ad Council on a national public service campaign to raise awareness about prediabetes. The Ad Council provides pro bono services for development of materials, so there's very substantial in-kind value for this effort. Campaign website has links for a brief self-administered test for risk of prediabetes in zip code locations where the NDPP is offered. There's been substantial traffic as of spring this year. More than 3.4 million people have visited the website and completed the prediabetes risk test. More than 124,000 visited the National NDP website to find the location of a program. The lingering issue is that gaps in awareness for those with prediabetes and familiarity with the NDPP may still be significant, probably are still significant, and this may be reflected in NHANES data showing that only about 15% of adults with prediabetes are aware of their status, and that's led us to this recommendation to increase support to the CDC for its role in the continuation of this campaign. And one possible direction for that increased support could be to enhance specific strategies within CDC cooperative agreements, two of them, one with state and local health departments, the other with affiliates of national organizations. In both cooperative agreements, the grantees are charged to increase the awareness of prediabetes and the NDPP in high-burden populations and underserved areas. A second recommendation is expanded coverage for tests used to confirm prediabetes. With background, the criteria for abnormal blood glucose levels and diagnosis of prediabetes have been established for 3 tests, that is for fasting blood glucose, for oral glucose tolerance test, and hemoglobin A1C. Medicare does not cover hemoglobin A1C testing for the purpose of prediabetes screening. The issues being that the 2 tests that are covered present logistical complications, that is, required fasting state of the patient or extended length of the clinic visit. We'd also note that the 2015 Preventive Services Task Force recommendation and the 2018 ADA guidelines for standards of medical care cite all 3 tests, fasting blood glucose, oral glucose tolerance test, and hemoglobin A1C, as equally appropriate tests for clinicians to consider in screening and testing for prediabetes and diabetes. And on that basis, we've recommended that CMS should provide coverage for hemoglobin A1C testing when used to screen for prediabetes. Our third recommendation involves a new clinical quality measure for screening of abnormal blood glucose. In December of 2019, the AMA proposed 3 new electronic clinical quality measures for review by the National Quality Forum to monitor and improve quality of care for patients with prediabetes. I've reproduced in italics the measure that's specific to screening and diagnosis, and that is percentage of patients aged 40 years and older with a BMI greater than or equal to 25 who are seen for at least 2 office visits or at least 1 preventive visit during a 12-month period, who were screened for abnormal blood glucose at least once in the last 3 years. I should say that this measure that was proposed was derived from the 2 guidelines that I had mentioned before, the 2015 Preventive Services Task Force guidelines as well as 2018 ADA guidelines. Both sets of guidelines indicate use of all 3 tests for screening purposes. The issues being the analysis of data, again from NHANES, showed that a high percentage of adults meeting those screening criteria proposed by the Preventive Services Task Force and ADA guidelines reported not being screened for diabetes in the past 3 years. A separate but related issue is the need for guidance on the interpretation and follow-up of random, a fourth measure, random, that is to say non-fasting blood glucose tests when the results are not available for recommended screening modalities. And so our recommendation is endorsement and promotion of this clinical quality measure by all federal agencies that directly deliver or influence the delivery of care. So our fourth and final recommendation for this particular focus area, use of existing administrative data to identify patients meeting criteria for prediabetes. In way of background, analysis of electronic medical records and laboratory claims data show testing for glucose or A1C levels has become more common in middle-aged and older adults. But on the other hand, the opportunity to identify a patient with prediabetes and to make a referral to a prevention program may have been missed during an acute or routine visit due to competing priorities or incomplete information at that time. So all of this, suggests the potential for administrative data that could be queried to create a registry of patients meeting criteria for prediabetes, for example, on the basis of BMI, other characteristics, or an abnormal glucose or A1C result. Patients in the registry could be contacted by clinic staff to discuss prediabetes and opportunities to enroll in the NDPP, and then the patient's medical record could be flagged for reinforcement of these messages at a future visit. And so this leads to our recommendation that federal agencies that deliver care, such as VA, DOD, and Indian Health Service, should systematically use administrative data to identify patients already meeting criteria for prediabetes and to confirm appropriate follow-up. So those are the recommendations for this first focus area. For the second focus area, improving access to and utilization of evidence-based effective type 2 diabetes prevention interventions, my colleague Shannon Idzik will present.
Thank you very much. So focus area 2 was about improving access to and utilization of evidence-based effective type 2 diabetes prevention interventions. And for this area, our first recommendation is related to metformin and prediabetes. So we all know there's a body of evidence to support metformin in delaying the onset, but metformin does not have FDA approval as an indication for prediabetes. And the issue with that is that FDA has not issued an approval for metformin. We don't know if they have reviewed it and declined it or if it's been brought forward in any way, but it has not issued an approval for prediabetes use. We all know that FDA approval has implications in terms of coverage and payment and potentially prescribing because it is considered off-label use. So our recommendation is that we consider available data on the use of metformin for delay of type 2 diabetes. Our second recommendation is related to an interagency coordinating body. And the background in this particular topic is that in 1974 there was the establishment of the Diabetes Interagency Coordinating Committee, otherwise known as the DMICC, which is chaired by NIDDK and other members of the Department of Health and Human Services. The role of the DMICC is to coordinate, collaborate, and communicate among diabetes groups in these government entities. Currently, there's a lack of understanding of how the statutory authority and scope of the DMICC aligns with the recommendations of the NCCC around the coordination. Our recommendation is that we identify or establish a federal interagency coordinating body within HHS to review, support, promote, and implement proven evidence-based programs shown to be effective in preventing or delaying type 2 diabetes. Our third recommendation surrounds modes of delivery for diabetes prevention strategies. The background is that there's experience with delivery of evidence-based interventions to delay or prevent type 2 diabetes among a variety of modes across federal agencies. Yet there's variation in coverage by private and public payers for varying delivery modes that have evidence of successful patient outcomes in delaying or preventing type 2 diabetes. The national DPP quality standards are also reviewed every 3 years and are submitted for public comment. The issue in this area is that there are barriers to access to evidence-based type 2 diabetes prevention and delay interventions. And offering these interventions through a variety of modes of delivery may increase access. However, coverage for alternative delivery modes varies across payers. Our recommendation is that coverage for all proven modes of delivery for evidence-based interventions that produce successful patient outcomes that are consistent with the national DPP quality standards in delaying or preventing type 2 diabetes. Our following recommendation is related to the CDC recognition process and CMS payment process for the national DPP and MDPP. So in response to this growing rate of diabetes and prediabetes in the U.S., the Congress authorized CDC to establish the National Diabetes Prevention Program in 2010. And the National Diabetes Prevention Program is a public-private partnership that really works to and creates a framework for a trained workforce, national quality standards, and as well as a network and participant referral and engagement. So CMS and CMMI and CDC are collaborated to create this, the Medicare Diabetes Prevention Program expanded model. In 2017, the Physician Fee Schedule, or the PFS, established a framework for the expanded model, enabling the national DPP program to delivery organizations within the CDC to enroll as MDPP suppliers. So one of the challenges here is that some organizations in rural and underserved areas experience challenges achieving both preliminary or full CDC recognition and applying to become MDPP suppliers. Our recommendation, obviously there are certainly efforts going on in those agencies to streamline these issues, and our recommendation is that these organizations continue efforts to streamline CDC recognition process and the CMS payment process for the national DPP and MDPP while maintaining quality. The following recommendation is related to the MDPP as a covered benefit and the once-in-a-lifetime limit. So in regard to the background of this topic, the CMMI, obviously you can read that initial part, I'm not going to read it all to you, but MDPP is one of these expanded test models through CMMI. And there are many requirements for this expanded model. The Medicare DPP continues as an expanded model test. There will be a final evaluation as described in the Act itself, and it is a covered service under the model demonstration, not currently a benefit. In the current CMMI Medicare DPP, there's also a once-in-a-lifetime limit on the Medicare DPP service. And so based on the findings, we also know from the original DPP, there is a significant amount of evidence, and that intervention has been studied extensively. The issue on this topic is that the future of the MDPP as a covered service will be determined by the outcome of the CMMI model demonstration evaluation. Full virtual delivery of the MDPP is not currently included under the expanded model, and this may limit CMS's ability to enroll a sufficient number of Medicare beneficiaries required to evaluate the expanded model. Virtual delivery of makeup sessions is part of the MDPP expanded model as described in the 2018 PFS. There may be additional variables that impact participants' ability to fully engage in or complete the program that may warrant additional intervention, and that there may be dose-related impacts. So our recommendation is that the MDPP is approved as a covered benefit, not only a model expansion service, and that the once-in-a-lifetime limit is lifted on MDPP as a covered service. Our final recommendation is related to the reimbursement rate of the MDPP. The reimbursement rates are set in the PFS and adjusted annually. Reimbursement rates may not, the issue is that reimbursement rates may not fully incentivize centers or programs to apply. The current MDPP payment rates may not be sufficient to cover the expenses of the program, and currently only a limited number of eligible organizations with CDC preliminary or full recognition have applied to become MDPP suppliers. Reimbursement rates may have a disproportionate impact on smaller or rural programs, and our recommendation is that there's an increase in the reimbursement rate for the MDPP. Our final two recommendations are related to Medicare coverage, or Medicaid coverage. Medicaid coverage for the national DPP is a state-level decision, and the national DPP is delivered in various evidence-based delivery methods. 17 states since 2012 have achieved Medicaid coverage for the national DPP. The issue is that there is variability across states in terms of whether or not the national DPP is a covered benefit within the state's Medicaid program, and there's variability in the delivery modes and the level of reimbursement authorized. We know that risk factors for diabetes are higher in the Medicaid population, and our recommendation is to increase the number of states that choose to cover the national DPP and other evidence-based interventions that produce successful patient outcomes consistent with the national DPP quality standards in delaying or preventing type 2 diabetes within their Medicaid programs, and to promote state Medicaid coverage of all proven modes of delivery for evidence-based interventions that produce successful patient outcomes consistent with the national DPP quality standards. And with that, I will turn it over to Dr. Howard Tracer for Focus Area 3, Sustainability of Type 2 Diabetes Prevention.
Thanks, Shannon. So this is Howard. At this point, what I'd like to do, because there's a lot of information that people have heard. First, thank you, David, and thank you, Shannon, for presenting those recommendations. And I want to open it up for any questions that the Commission has about Focus Area 1, Screening and Diagnosis, or Focus Area 2, Access and Utilization. And then I'll start my focus area. So questions.
This is Bill Herman. I had two quick questions for David. David, you mentioned the problem with the awareness of prediabetes, and only about 15% of people with prediabetes are aware of the diagnosis. It sounded like both recommendations 1 and 4 might increase awareness, but your first recommendation, I think, was that the CDC activities focus on increasing awareness among medically underserved populations. Though that's important, I would suspect that with the low level of awareness, we need something that might be more broad-based. Can you comment on that, and are there any mechanisms to increase general public awareness of prediabetes?
Yeah, the cooperative agreements that I mentioned, and there's actually a third one that goes to all states, and they would address issues related to awareness and familiarity with the NDPP for the general population. So they have, in addition to that sort of general mandate, for the 2 cooperative agreements I mentioned, there's a specific charge for extending outreach to underserved and high-burden populations. So when I mentioned, the increased funding and the opportunity to enhance that, that wouldn't necessarily be at the exclusion of the more general campaign to increase awareness and to increase familiarity with the NDPP. I know that Ann Albright is, I think she is on the phone, and so I don't know if she wants to add anything more to that.
Yeah, thanks. The public awareness campaign that we're doing with the American Medical Association is the entire population. But of course, anytime you do a marketing campaign, you do have to have a target audience identified. Otherwise, your message doesn't resonate. So, and we have altered that target audience a bit over the course of this ad council campaign. So it may be sort of an age range that's more 45 to 60. It may also be a bit heavier focus on men who are underutilizers of the intervention and those kinds of things. But that ad council campaign is aired for the entire population to see. Our funding opportunity announcements, the 3 that have been identified, have varying time courses. They will last for 5 years each, and that's why we call them numbers. If you hear the numbers 1705, 1815, 1817, it means those funding opportunity announcements, which become cooperative agreements when funded, started in 2017 or started in 2018, and so they run for 5 years. So those particular ones that go to the states or national organizations, it is indeed to increase the awareness and, more importantly, the program uptake by those populations. So there is, as was mentioned, still efforts that reach the entire population, but hopefully that's clear that the Ad Council campaign really hits the entire population. And we have to also have additional efforts that focus on high-risk adults who are underserved.
Great, thank you.
And I think Carol.
Okay, so I just wanted to clarify from David the clinical quality measure developed by AMA, was that to be utilized only among federal agencies who take care of patients, or was that for CMS to adopt for all practices? I just needed clarification.
Those three, it was actually three measures that AMA has led the group. CDC serves on that expert panel, as do a number of other groups. There were three measures that were developed. They are intended to be used by commercial entities, so any healthcare institution. But of course, they matter most if you get them into CMS and they become a part of payment. So currently, one of those measures is under consideration on the MUC list. It is actually referral to a national DPP program. But our hope is that ultimately all three will be utilized, because you do indeed have to identify people, then you need to refer them, and ideally you need to have follow-up, and that's what those three measures are. But currently the only one actively being considered by CMS for payment on their MUC list is the referral to the national DPP or medical nutrition therapy. But directly your answer is it's to all healthcare entities, but CMS pays and most follow, so it's important that we have them as part of the payment programs that CMS has in place.
And then I only mentioned the first of the three since it was the one that was specific to that focus area of screening and diagnosis.
Got it. And then I had a question for Shannon, or a comment. I've heard from many people or several, who've been trying to start or participate with the DPP, the Medicare DPP, that the upfront cost where they are having to provide the DPP before they qualify to get paid is one of the biggest barriers. And I'm assuming in the report you're going to address the necessity for these community organizations who often don't have a lot of funding to have to pay. I mean, they get no income, but they're providing the DPP until they qualify. Is that going to be addressed somewhere when you talk about streamlining? Is that included in the streamlining?
So Carol, I'm glad you brought that up. I don't think that actually was in our conversation specifically, but a valuable point for us to include in there. There's lots of conversation about the overhead expense in general, but not specifically, I don't recall, about the upfront time intensity, which obviously equates to cost.
Yeah, Carol, let me just also, again, eager to hear folks' suggestions. Most payers require that there is demonstrated capability before they will pay. So we're in a pay-for-performance world, pay-for-outcomes. So what we at CDC have been trying to do, of course, our grant funding has helped a number of community-based organizations. That's why those cooperative agreement numbers that were shared are directed at those in high-risk communities and provide money for them to train coaches, to start up programs, and we certainly work with other partners to do that. But we are also trying to, because when our funding goes away, though, those programs will never survive, and unfortunately that's a flaw that happens in public health. We will start these things, and then there's no long-term sustainable funding. So then you have to show your ability to demonstrate a quality program. So we have also focused on making sure that these smaller organizations are now, we're testing a model now in which they will join together under the sort of oversight, if you will, or connection to a larger entity who can afford things like the HIPAA lawyer that's needed if you're going to become a Medicare supplier, the cost for training your coaches, and the cost for getting, again, payment to your coaches to deliver the program. But it's difficult and not a long-term sustainable scenario if you're going to have a number of organizations try to start up
with no demonstrated ability to deliver the intervention, or being paid to start it up but have no idea whether they're going to be able to be sustainable. So again, that's why at CDC our portfolio is trying to deal with both ends of that challenge. Certainly more that can be done if there are organizations who are community funding organizations. We oftentimes encourage those organizations to look at local funding sources. In our National DPP Operations Center, we have an application that will continue to post funding sources for organizations. So we're really trying to approach it from that perspective so we don't get folks trying to start a program. They wouldn't be sustainable long term anyway without a funding source. It's really not probably the best use of their time and energy to try to start up a program.
Thank you.
Howard, this is Dean. I'd love to ask a question if there's time.
Oh yeah, please go ahead.
Yeah, okay, this is for David. So this is very exciting to see the proposals for enhancing the scale of the national DPP. And obviously it presents a major challenge if we have 30 to 40% of the population by different criteria having prediabetes. We're talking about delivering this to something like 90 million people in the country. But it also presents an opportunity, I guess, for thinking about this from a precision public health standpoint. And we talked about this a bit in September, so I'd love to hear if you guys have done any more thinking on this. Well, recall that the DPP itself, the original trial, enrolled people who had elevated, they both had impaired fasting glucose as well as screen positive on the glucose tolerance test. So they were a fairly small subset of the larger population that now is being considered to have prediabetes. And the question is whether or not there is an opportunity to make a recommendation around additional research that would allow us to identify the subset of people among whom we are currently designating them as having prediabetes who might have the kind of prediabetes that we believe will lead to a trajectory of incident diabetes in some period of time. Because right now we will be delivering the DPP to a large number of folks who may or may not go on to develop diabetes. And while there are obviously salutary benefits to weight loss, wondering whether or not there's an opportunity to do research on new techniques to identify the subset of people, maybe it's 10 million or 20 million instead of 90 million, who really could benefit from what in reality is a fairly intensive intervention as far as public health interventions go. Thank you.
I think that would be a good topic for our fourth focus area for research, and we'll see if when we present that, if there's some mention or some aspect of our recommendations that includes that greater focus in terms of who might benefit from the NDPP. I guess the other point I would make also is that when we look at the effects associated with prediabetes separate from going on to develop or be diagnosed with diabetes, there's evidence to suggest that there are other kinds of effects. I know that with cardia they've identified coronary calcium and other subclinical measures. So I think that that's also part of the dilemma also, that there is evidence of risk associated with being in that category.
So I was going to add a little bit, and I think probably the best predictor is either higher glucose levels or higher A1C levels that we know about. And then when we do get to focus area 4, John will touch on that a little bit around heterogeneity of prediabetes. So
yeah, and I just to say that there's a burgeoning field in metabolomics where increasingly they are able to predict with greater precision those who will go on from those who won't. And I can't remember what the incidence rates were in the DPP trial, but potentially we're giving a fairly intensive intervention to a lot of people who aren't going on to develop diabetes. Again, I agree it's completely beneficial to do so, but from an attributable risk reduction standpoint, I'm wondering whether the metabolomics world might have something to help. Thanks.
Yeah, I guess two things. John will be, I don't want to talk about John's presentation, but we'll be talking a little bit about that and also perhaps other approaches to, again, more in the future, other approaches to diabetes prevention that maybe are a little bit less intensive, but that we don't know work yet. Other questions? Otherwise, I'll start with focus area 3. Okay. Let me go ahead then. So my focus area 3 is about sustainability of type 2 diabetes prevention, and want to thank my work group members, Barbara Lindner and Barry Marks. So this is really the starting point for sustainability. I know the Commission's familiar with the Diabetes Prevention Program study. That's sort of foundational for our subcommittee. And in that study, as you know, intensive lifestyle and metformin were effective in reducing the risk of diabetes over about 3 years. The big issue is that we don't really know the optimal strategy to sustain decreased diabetes risk over the longer term. And so really briefly, I'll just go over what we do know about diabetes prevention in the longer term. And it really is limited. Just want to talk briefly about the Diabetes Prevention Program Outcomes Study. And that was an open label, so to speak, follow-up of the DPP. And in the DPP Outcomes Study, maintenance group lifestyle sessions were offered quarterly to all prior DPP participants, so everybody. So in a sense, the DPP-OS, even though I'll talk about metformin group and placebo group, really you get sort of a blending of those groups because it's not a controlled trial anymore. And I believe at the 15-year follow-up, diabetes incidence was lowered by 27% in the lifestyle intervention group, 18% in the metformin group, compared to, again, not a true placebo group. Those reductions are lower than the 58% seen with lifestyle and 31% with metformin in the initial DPP, the first 3 years. And that, though, gives you some sense that lifestyle and metformin have some ongoing benefit to prevent diabetes in the longer term. Again, it's hard to be sure what that is. Another important point is that the reduced differences during that outcome study represent a reduction in the incidence of diabetes in the placebo and metformin groups who, remember, I just told you they were able to participate in a group lifestyle session after the clinical trial was completed. And Dean, you asked this question about progression rates. The progression rate in the follow-up to the DPP was about 5% a year. And that's actually the rate that was recorded in the lifestyle group in the DPP itself. So as the last bullet, one possible, and again, it's only one possible explanation or perhaps one factor among many, but one possible explanation is that offering group lifestyle interventions quarterly to all the participants might have been, as I said, one factor responsible for reducing the further development of diabetes. So, summarizing the background, the DPP demonstrated the effectiveness of lifestyle and metformin to reduce the risk of developing diabetes over 3 years. However, that risk of developing diabetes persists over time. In the DPP, again, getting back to that question, in the DPP, about 29% of those in the placebo arm progressed to type 2 diabetes over 3 years. And that is a fairly high progression rate. In the longer-term follow-up DPP-OS, about 52% of those in the placebo group, again, asterisk to remind you that it's not a true placebo group, progress to type 2 diabetes. There's another very important consideration when we think about long-term diabetes prevention, and that is that microvascular disease and macrovascular disease are major causes of morbidity and mortality for people with diabetes. And people with pre-diabetes, I think as we were just talking about before, are also at increased risk of cardiovascular disease. Therefore, prevention of cardiovascular disease and other diabetes-related health outcomes is an important goal of diabetes prevention interventions. In the diabetes prevention program study, intensive lifestyle intervention did reduce cardiovascular risk factors such as blood pressure, lipids, and weight. So again, getting back to what we were talking about a few minutes ago, additional potential benefits there. So decreasing risk of diabetes, but also decreasing cardiovascular risk as well. And right now, though, we have limited information about the effects of diabetes prevention interventions on cardiovascular disease and other diabetes-related health outcomes in the longer term. So that's something that we need to know more about. So summarizing the issues, the best way to prevent progression from prediabetes to type 2 diabetes in the long term is uncertain. Cardiovascular disease is the leading cause of morbidity and mortality in persons with diabetes, and people with prediabetes are also at increased risk of cardiovascular disease. However, the effect of lifestyle interventions in metformin on risk of CVD and other diabetes-related health outcomes in people with prediabetes has really not been well studied. So our recommendation to funding agencies, primarily NIH and CDC, is that the NCCC recommends more research on the number, frequency, and content of, we'll call them booster doses, lifestyle intervention sessions needed to effectively sustain weight loss and type 2 diabetes prevention in the longer term after successful completion of an initial diabetes prevention intervention. As part of that recommendation, we think that studies on the effectiveness of metformin and combined approaches, so that would be metformin plus or medication, if proven effective, plus lifestyle intervention to prevent diabetes in the longer term are also needed. So perhaps you need a combined approach, or a combined approach might be more effective than a single approach. And also studies on sustaining type 2 diabetes prevention over the longer term should also capture the effect of these interventions on the risk of diabetes-related health outcomes. So important endpoints like CVD and other diabetes complications, microvascular disease. Moving on to insurance coverage and its role in sustainability of type 2 diabetes prevention. So in practice, insurance coverage of benefits is a major determinant of their implementation and availability. And I think as we've heard, the issue is if insurance coverage is lacking or reimbursement is insufficient, then the availability and implementation both of the proven diabetes prevention program and longer-term diabetes prevention interventions is going to be hindered. So our recommendation to CMS is NCC recommends ensuring that coverage and reimbursement are included in the payment system, that would be Medicare, Medicaid, for evidence-based strategies that sustain long-term diabetes prevention. Now, we discussed in our subcommittee, it's hard, obviously, to recommend something that isn't known yet or isn't proven yet, but we want to be proactive here. So as the recommendation sort of is refined further, the idea is how can we be proactive about getting insurance coverage and appropriate reimbursement for new evidence-based strategies as the evidence emerges, so that there isn't a lag and there isn't an issue with uptake. So more conversations, I think, with CMS will be helpful in refining this recommendation. And then from, I guess, a public health or population standpoint, this will lead to my last recommendation about sustainability of type 2 diabetes prevention. I think as the Commission knows, type 2 diabetes is an increasingly prevalent condition. An estimated 34 million Americans have diabetes. 88 million adults have prediabetes, about a third of the population. And again, as you know, racial and ethnic minorities are disparately impacted by diabetes. Non-Hispanic blacks have the highest prevalence of diabetes among populations in the United States. The estimated costs related to diabetes are $327 billion yearly. Studies have shown that evidence-based interventions to reduce the risk of diabetes, for example, the DPP, are cost-effective. The overall incidence of diabetes in 2018 is about the same as it was in 2006. So over that time, there's been an initial increase, and there has been something of a positive trend since about 2008, 2010. But unfortunately, the incidence has been increasing in youth. So while we're starting to see a decrease in adults, the incidence of diabetes is still increasing in youth. And from DPP and from other examples that I'll talk about in a minute, we know that it's possible to prevent diabetes. However, doing so is going to require a sustained government focus on diabetes prevention. So as one example, as we've recently heard, the Indian Health Service was able to lower the prevalence of diabetes in high-risk population, American natives, consistently for 4 years, dropping the prevalence from 15.4% in 2013 to 14.6% in 2017. So this is possible to do. So again, as a summary, type 2 diabetes is increasingly prevalent. It's associated with significant costs, morbidity, and mortality, and disparately affects certain racial and ethnic minorities. We know that decreasing the incidence of type 2 diabetes is possible, but it's going to require a sustained focus on diabetes prevention. The issue is that federal agency funding priorities shift over time, and while understandable, in order to decrease the prevalence of type 2 diabetes, we need to maintain a continued focus on preventing diabetes. And federal grants to improve community health don't always specify diabetes prevention as a priority. So our recommendation both to funding agencies and federal agencies that provide care is that federal agency initiatives and programs targeting type 2 diabetes prevention need to maintain a continued commitment and a continued focus on prediabetes and preventing type 2 diabetes. And that ends my recommendations. So I'll open it up for questions now.
Hi, this is Sherry Bowen. I just had a question, and I may have missed something because there was a lot of great material in all of the areas. But one of the challenges with our Medicaid patients is the variable coverage by state for DPP. And a lot of that relates to the fact that there is a 2-year Medicaid budget or a limited Medicaid budget in select states. And so the benefits in terms of cost in a budget can be challenging. So I didn't know if any of our recommendations, I didn't see it here, but maybe I just missed it, relate to a way to get Medicaid coverage more broadly across the states. And I saw some things about trying to get states to adopt, but I just wasn't sure. I may have missed some of the detail.
Yeah, so definitely more details to be worked out. In focus area 2, I believe it was focus area 2, we did discuss trying to get more states to cover, I think only 17 states cover Medicaid DPP, and definitely as a focus area both for focus area 2 and 3, and of course some of the recommendations do overlap. That is definitely a focus of the subcommittee to improve Medicaid coverage for DPP.
And have you guys figured out how best to do that? And I guess I'm also thinking that this may have some inferences for making alignments across subcommittees where we're making recommendations around DSME, which also has variable coverage by state Medicaid.
Yeah, that's and I don't know if Shannon can also speak to this. It's a challenge. It's my understanding, unfortunately, that the states can decide to cover or not cover DPP. Shannon, anything else?
Sure. So one of the conversations that came up was the current incentives and how, for the federal level incentives for states to do it, and how can we bolster those federal incentives for them to do it. That was one conversation. The specifics of how to make that happen might be challenging.
And Pat Schumacher should speak up. CDC has actually done a demonstration project with states, and we actually are responsible for working with everybody who's implemented in the 17 states. So, Pat, do you have some info to offer?
Yeah, part of the benefit of the demonstration project was lessons learned from the practical application of a state going through this process, deciding to cover, rate setting, doing all of those things. So we were able to document that in a couple of states and also form a learning community with other states who could benefit from learning from the states that have made those decisions and gone down that path. So those have been helpful.
So I guess I'm just thinking about, if there's any recommendation that you end up making around this, it might be useful to, Jasmine and Carol, I'm thinking about our DSME recommendations and whether there's any thoughts about trying to make a similar, just aligning a recommendation around that if there's one to be made.
This is Ann already, and I would say that there are probably a few things that the commission is doing here. There's been talk of a group in the federal government that will have the ability to sort of oversee, and that's probably not a good word to use, but will have the ability to try to help coordinate and move things forward. There are no doubt other themes that will emerge that are likely should be tackled by overall the commission as opposed to one area, one subgroup making that recommendation, and this is likely one of those. So I'm sure there'll be a group of those as we all further our recommendations.
And I was going to say the same thing. This is Jasmine, that I had noticed areas of alignment that I thought we could eventually coalesce as we all move forward.
Your subcommittee's presentation on virtual care and digital divide obviously is relevant to virtual DPP. So again, a lot of synergies. Okay, so we have about 10 minutes left, maybe time for one more question, and then I want to give John time. So give it a second. Okay, let me turn it over to John Boltry then, who will discuss our focus area for new and more effective preventive strategies for type 1 and type 2 diabetes. Okay, John?
Thank you, Howard. So the members of this focus area also include Barbara Linder and Ellen Leake. And this area focuses on research on prevention that has not been covered in the other areas. So first we're going to talk about type 2 diabetes research. We've already heard a lot about the National Diabetes Prevention Program. The National Diabetes Prevention Program was based on a large national study that showed the risk of type 2 diabetes could be reduced by 58% with a lifestyle change program when people participated in a 16-session program followed by monthly support sessions, and also a 30% reduction with metformin. In follow-up to that study, the NIH has continued to support research addressing translation, dissemination, and implementation of the diabetes prevention program. The NIH has also funded behavioral science research focused on how to maintain successful weight loss for people who participated in a weight loss program. In spite of there being a proven effective diabetes prevention program, a majority of patients with prediabetes have not participated in an effective diabetes prevention program. There are also disparities in implementation and uptake of the diabetes prevention programs, which might be exacerbated by social determinants of health. These causes of the low rates of uptake of diabetes prevention programs, the causes of them are not well understood. There are also few medications proven to prevent or delay the onset of type 2 diabetes. Finally, most people who achieve weight loss from diabetes prevention programs regain the weight. Therefore, the National Clinical Care Commission recommends funding to promote widespread implementation of the most effective in-person and virtual diabetes prevention programs. The NCCC recommends funding to support studying impediments to participation in effective diabetes prevention programs, especially for communities that need diabetes prevention programs the most. The NCCC recommends funding to disseminate new knowledge about effective diabetes prevention programs, both in-person and virtual, as this science evolves. Number 2, the NCCC recommends funding to support research to better define the heterogeneity of prediabetes and type 2 diabetes in order to understand the intervention response by particular people that can inform the development of personalized medicine approaches. And this recommendation might be amended to include the recommendations that Dean made earlier in this presentation concerning are there subgroups of people who might benefit more from DPPs than others. And the third recommendation here is that the NCCC recommends funding for behavioral research to understand the barriers to long-term maintenance of weight loss achieved in diabetes prevention programs and methods to help people maintain weight loss long-term. Moving on to type 1 diabetes research. Up to 10% of all people diagnosed with diabetes have type 1 diabetes. Type 1 diabetes is a condition that develops due to an immune-mediated destruction of insulin-producing beta cells in the pancreas, which causes the body to stop producing insulin. Occurring most often in children and young adults, this type of diabetes appears suddenly and can lead to lifelong health complications. Relatives of people with type 1 diabetes have a greater risk of developing the disease. In spite of improvements during the past decades, approximately 30% of people with type 1 diabetes present with new-onset diabetic ketoacidosis. The Special Statutory Funding Program for Type 1 Diabetes Research, or Special Diabetes Program, is a special appropriation that supports research on the prevention and cure of type 1 diabetes and its complications. Since 1998, the Special Diabetes Program has enabled the creation of unique, innovative, and collaborative research consortia and clinical trials networks. The NIDDK administers the Special Diabetes Program on behalf of the Secretary of the Department of Health and Human Services and in collaboration with multiple NIH institutions and with the CDC. The Special Diabetes Program supplements type 1 diabetes research supported by the NIDDK and the NIH regular appropriations from Congress. So research is needed to understand if there is a targeted group of people to screen and treat for prevention of type 1 diabetes. Work is needed on how to best leverage emerging data from TEDI and TrialNet to develop precise and effective screening programs that could be used to identify those at high risk who might benefit from interventions. DKA, diabetic ketoacidosis, is a serious condition that can lead to diabetic coma and even death. It would be helpful if people at risk for type 1 diabetes could be identified before they present with DKA to prevent the development of DKA. The Special Diabetes Program was originally funded for 5 years, but the program has most recently been funded only on an annual basis. Annual funding inhibits the opportunity for significant research programs because research projects require multi-year funding to be successful. I want to share some information on type 1 diabetes research that demonstrates the importance of the Special Diabetes Program. TrialNet is an international clinical trials network sponsored by the NIH, which conducts studies to find ways to prevent or delay the development of the disease and to enhance treatment for those newly diagnosed with type 1 diabetes. The current TrialNet study is an example of what is currently being funded. TrialNet 10 is a phase 2 prevention trial studying the effect of teplizumab on insulin production in the relatives of people with type 1 diabetes who are at high risk of developing the disease. TrialNet 10 is projected to last 4 to 6 years with an enrollment period of 2 to 3 years. And the approximate enrollment of the study is 140 to 170 individuals between the ages of 8 and 45 years old. Participants are randomly assigned to either the active or placebo group of the study and monitored and tested over time until diagnosed with diabetes. So here is the recommendation. The NCCC recommends funding the Special Diabetes Program in 5-year increments so that new, innovative research can effectively be developed. And that's the last slide. We will open it up to questions. Dean, did you feel like we could incorporate your suggestion into recommendation 2, which was better defining the heterogeneity of prediabetes?
Yes, I think with some wordsmithing, I think that's an excellent place to put it. And I will try to send you some of the metabolomic literature that I've seen.
Thank you.
Good. Well, this is Bill Herman. John, I want to thank you and the rest of the Prevention Targeted Population Subcommittee for the great presentations. We are running about 10 minutes behind. I'd like to give you all a 15-minute break. So if we can we plan to reconvene at 3:35. At that point, we'll start with the Prevention General Population Subcommittee update. So let's take a break now and be back in 15 minutes. Clydette, do you want to go ahead with the roll call?
Certainly, Bill. Can you all hear me?
Yes.
Great. Thank you all for joining after the break. We will begin with a roll call. William Herman.
And I am here.
Ann Albright. Present. Howard Tracer.
Present.
Barry Mark.
Present.
Naomi Fukagawa. Present. John Shell.
Present.
William Chong.
Present.
Aaron Lopata.
Present.
Barbara Linder.
Present.
Paul Con.
Here.
Dokun. Carol Greenlee. Here. David Strauss.
Present.
Dean Schillinger.
Present.
Ellen Leake. Present. Jasmine Gonzalvo. Present. John Boltree.
Present.
Meredith Hawkins. Present. Shannon Isaac. Present. Sherry Boland. Here. William Cook.
Here.
Ayatundi Dokun.
Here.
Great. And as mentioned at the start of the meeting, both Ann Bullock and Captain Samuel Wu have excused absences. So we have a quorum, and I'll pass this back to Dean, to Bill, to introduce Ann and Dean. Thank you.
Good. And Dean, we'll turn it over to you. It's now 3:37. I'd like to give you a full hour, so you'll have until 4:37 Eastern Time for your presentations.
I will now, thank you, I will now present an update from the General Population Subcommittee, and we'll be doing that in concert with a number of my colleagues who are listed here. I want to thank my colleagues as well as Dr. Powell and Jennifer Gillison. We've been extremely busy over the last 2 months, and I deeply appreciate all the work that has gone into preparing this presentation. I also want to say that Ann Bullock, as Claudette mentioned, could not be present today, but the work that we will present here very much represents a lot of time and effort that she has invested in this subcommittee. So the outline for today's presentation is to review the General Population Subcommittee's framing statements very quickly, orient today's focus by taking a look at where in the diabetes prevention and care model we will be focusing on, review the rationale and alignment for our work with the charge of the NCCC based on the original charter, and then provide updates on the literature search and key informant presentations that we have received since the September meeting. Review the topics that we have made draft recommendations on in our prior September and previous June meetings, and then present a set of new draft recommendations. And if I understand, Bill, you would like us to pause after each recommendation for question and answer, which we will do, and then describe next steps. So to remind folks, the General Population Subcommittee is focusing its recommendations on the issues related to type 2 diabetes for the most part, because type 2 diabetes is widely acknowledged to be a consequence in part of the social and environmental context in which we live. And I also want to remind us that while the subcommittee is making recommendations that relate to large subsets of the general population, it's important to appreciate that all of the recommendations that we'll be making actually will directly impact the lives and self-management capacity of those living with diabetes, either type 1 or type 2, and those who are living at high risk of developing diabetes, so those with prediabetes. So the recommendations very much relate to the work of the prior two subcommittees. And in the future, we will be working to more clearly harmonize those. But I encourage you as we go along to be thinking about how these recommendations may impact those individuals who reside in subcommittees 1 and 2 from today's presentation. The framing statement I included just for comprehensiveness. We have reviewed this before, but I want to remind us that there is language in the NCC charter that specifically lines up with the kinds of recommendations we are going to be making, that we've made before and will make today. And that is that in the charter, the Secretary has been asked to establish a committee that relates to improvements in the coordination and leveraging of programs within the department, but also across other federal agencies. In addition, again, a mention of improved coordination across federal entities, and specifically thinking about the work that can be done to support clinicians in providing high-quality care to individuals with diabetes, its complications, and those at risk of diabetes. And so I wanted to frame today's conversation a little bit from the standpoint of how clinical organizations and clinicians themselves are thinking about the social and environmental factors. So we know that the National Academy and the American Diabetes Association have recently come out with very important reports highlighting the serious problems that such factors and exposures create with respect to providing and optimizing clinical care for people with diabetes. So that this is not simply to be thought of as a public health set of problems, but also a set of problems that impact healthcare quite directly. Clinicians now are being asked to routinely screen and refer for social services such as food and housing. Yet we know that clinicians who care for people with diabetes have been found to have very high rates of burnout as a result of feeling unable to address their patients' social needs that are getting in the way of their diabetes prevention and control efforts. Now, while social services embedded in primary clinics can buffer against burnout by increasing efficiency, restoring clinicians' medical roles, and improving morale, clinicians do view these clinic-level interventions to address patients' social needs as terribly insufficient as a strategy to care for diabetes and overcome burnout. And finally, increasingly, both private and public health plans, as well as CMS, have begun either making investments in addressing such factors or taking into serious consideration interventions that address these social environmental factors for the patients for which they are on the for which they pay the bill. Now, just to orient us as to where we're going to be focusing today, I did this last time in September, and I'd like to do it again today. If we look at the blue oval on the left in terms of the sectors of influence, today we'll be focusing on the areas that include housing, labor, communication and marketing, and the food system. In terms of behavioral settings, we will focus on the work site as well as home and community. To remind us, the relevant federal agencies for the work that we have been doing have included not only health agencies listed on the table on the left, but also a range of non-health agency, quote-unquote non-health agencies, whose policies and practices can heavily influence the degree to which diabetes occurs in this country and the degree to which the ability to self-manage diabetes is affected. And to that end, I'd like to report on the progress that we have made, first by reminding us of the recommendations that we have previously completed and are currently revising. We made previously 6 recommendations that fall into the following categories. 1, related to instituting health impact assessments for policies across non-health departments and agencies as they relate to the impacts they might have on the diabetes continuum. Second, we created a recommendation to reduce food insecurity and prevent and control diabetes by expanding SNAP eligibility, SNAP being the Supplemental Nutrition and Assistance Program administered by the USDA. Third, a recommendation to scale up and implement a fruit and vegetable incentive program as part of the SNAP package for all SNAP beneficiaries to incentivize the purchase of fruits and vegetables so as to better prevent and control diabetes. This will also increase the demand for fruits and vegetables, which could influence the desirability of increasing the supply. Fourth, we recommended eliminating sugar-sweetened beverages as a beneficiary in SNAP purchases so as to better prevent and control diabetes. Fifth, we recommended improving and expanding diabetes and education and awareness programs for SNAP beneficiaries that could include issues related to the topics discussed in Subcommittee 2 around the national DPP as well. 6, we recommended significant improvements in the food and beverage labeling policies and practices in the United States to better prevent and control diabetes, including the development and implementation of front-of-package icons with clear communication as to things like added sugar content, use of teaspoon units for added sugar in nutrition labels to enable ease of interpretation by lay consumers, and the increased funding for a communication campaign related to the new added sugar labeling regulations that the FDA is implementing. So those are our prior recommendations in brief. We have submitted a literature search related to diet and nutrition. I won't review this again today. The search has been completed, and now under the guidance and leadership of Claudette Powell at the Office of Women's Health, those results are being compiled, cleaned, and synthesized for our review. And lastly, since September 2020 at our last meeting, we have been actually quite busy bees in continuing with our key informant presentations. We have presentations from Dr. Chris Madsen on sugar-sweetened beverage regulation and taxation, from Dr. Martin White from the United Kingdom on food policy interventions being done in the United Kingdom, Sarah DeGia from Change Lab Solutions on a range of issues related to transportation, housing, and diabetes, Dr. Hilary Seligman from Feeding America and the UCSF Hunger and Food Policy Program on food policy as it relates to the food safety net and nutrition assistance programs, Heidi Allen from the Columbia School of Social Work around health insurance and healthcare access and its impact on economic viability. Craig Pollack from Johns Hopkins on the interrelationship between public housing, housing policy, and diabetes. Howard Frumkin from the University of Washington on a range of environmental health issues, including urban planning, transportation, and housing. Paul Ong from UCLA on issues related to transportation and health. Barbara Linder and Christopher Lynch from the NIDDK, who described the new nutrition initiative as well as a range of other research initiatives at the NIDDK. So the recommendations we present today represent a constellation and compilation of the literature, key informant presentations done during this time period as well as during the time periods before the September meeting. So I'd like now to pass the baton to Dr. Erin Lapata, who will be summarizing the background and recommendations for draft recommendations 7 and 8. 1 through 6 were presented briefly in previous slides. Thank you. Erin?
Thanks, Dean. So, want to start with some background. Given the breadth of the Farm Bill, a notable missed opportunity has been the lack of concretely linked aims between supporting farmers while meeting food security and public health and healthcare goals. The Farm Bill is a potentially powerful yet underutilized tool for preventing and controlling diabetes, curbing healthcare spending, and reducing disparities. And more should be done and could be done to fully leverage its potential. So what we've done is we've highlighted 3 USDA programs that this is what we wanted to focus on. One, the Specialty Crop Block Grant Program. This program aims to enhance the competitiveness of specialty crops. Specialty crops are defined as fruits, vegetables, trees, dried fruits, horticulture, and nursery crops. The second program is the Specialty Crop Research Initiative, which attempts to address the critical needs of the specialty crop industry and sustaining all components of food and agriculture, including conventional and organic food production systems. And finally, the Healthy Food Financing Initiative, which provides grants and loans to improve access to healthy foods by financing grocery stores, farmers markets, food hubs, co-ops, and other such retailers in urban and rural areas. Evidence shows that HFFI finance programs increase food security and reduce intake of added sugars, as well as declines in the percentage of daily calories from solid fats, alcoholic beverages, and added sugars. Next. Okay. So subsequently, our recommendation, NCC recommends that the USDA support more robust efforts to change the food supply in the United States so as to promote the prevention and control of diabetes by, 1, significantly expanding and increasing funding for the specialty crop block grants to support food safety and drive demand through the education for specialty crops, which again, fresh fruits and vegetables, to increase dietary diversity and as an aid to help people achieve the dietary guidelines for Americans. And second, recommend significantly increasing funding for the Specialty Crop Research Initiative grants for research on how to improve specialty crop production efficiency, handling and processing, productivity, and profitability over the long term, including specialty crop policy and marketing.
Aaron, please include recommendations, 8 as well.
Yes, I'm sorry. I was waiting for the recommendation 8. The NCC recommends that the USDA report more robust efforts to improve healthy food access in the U.S. As to promote the prevention and control of diabetes. And the recommendation 8 is significantly expanding and increasing funding for the evidence-based healthy food financing initiative. And this is again a federal effort to improve food access and health in low-income, underserved communities and communities of color in urban and rural areas and support farmers and healthy food retailers to improve access to nutritious, affordable, fresh food. Going on to the next slide.
I think we're going to, I believe we pause here now.
That's right. Wait for the record.
Yeah, Bill's request to see if, because the next one has to do with nutrition assistance programs, Aaron. So let's take a pause and see if folks have comments on or questions on draft recommendation 7 that's put here, increasing changes in food supply to increase fresh fruits and vegetable production, and increasing the sort of healthy retail transformation efforts. Together, these three programs represent 0.23% currently of the $86 billion Farm Bill. And so what Dr. Lapata is recommending is scaling these successful programs up.
Comments, questions, or concerns?
This is Bill Herman. A small percentage of a big number is still a lot of money, but it is remarkable what a small fraction of the Farm Bill these programs represent, and I think it certainly makes sense based on their proven effectiveness. So I certainly support these recommendations.
Thank you, Bill.
Okay, Aaron, let me, if there's no further comments, let me advance the slide to your next topic.
Okay. So these have to do with children's nutrition programs, school nutrition programs. The background, USDA provides nutritional assistance in several programs besides SNAP. Such programs not only reduce food insecurity, but have tremendous potential to prevent and control diabetes with a focus on pregnancy and early childhood. So the first program we discussed is the National School Lunch and Breakfast Program. It serves 30 million children a day. Since the inception of the Healthy Hunger Free Kids Act, or HHFK, incidence of obesity among low-income children who participate in the program has declined by 47%. Schools face challenges meeting the new nutrition standards, food costs, such as food costs and the availability of foods. Also, schools have talked about inadequate staff, training, equipment, and infrastructure. So those are the needs that schools have stated they have to implement the program. The HHFK nutritional standards are also at risk for being undermined if schools cannot more effectively implement this program. The summer nutrition program serves 3 million children. It's only 10% of enrollment compared to those eligible for the school lunch program. So there's room for this program to also expand, also noting that kids in the summer also have problems attaining nutrition, and it's harder to get these kids because they're not in school. Next program, the Fresh Fruit and Vegetable Program, introduces and provides children with a wide variety of fresh fruits and vegetables to prevent diabetes. This program increases fresh fruit and vegetable intake by 1/3 cup per day without increasing calories. And then again, there's a much greater demand for this program than there's currently funds allocated to implement this program. And finally, the Special Supplemental Nutrition Program for Women, Infants, and Children, also known as WIC. Since WIC's revised food package in 2009, has shown to reduce excess weight gain in women and improve birth weight, as well as reduce childhood obesity and all outcomes linked to diabetes risk. And the prescriptive food package is at risk of being undermined. Also, insufficient breastfeeding support is a concern, and inadequate technology infrastructure is a concern as well in terms of our ability to reach WIC customers and potential WIC customers. Next slide, please. So our recommendation is as follows, and it's there's multi parts to it. The NCCC finds that USDA's nutrition assistance programs that focus on the peripartum period and early childhood period, which are a critical time in the life course that influences diabetes risk, are effective in preventing diabetes and should receive additional support. Specifically, we recommend maintaining the nutrition standards found to be salutary, again, as detailed in the HHFK Act, providing adequate funding for schools to purchase, prepare, and serve healthy, quality foods and beverages for school meals and snacks to meet nutrition standards, and B, we call for USDA to deliver training and technical assistance to support maintenance and attainment of nutrition standards and skills to run a program to effectively prevent diabetes in the schools. Third, strengthening, increasing funding for, and improving access to and participation in summer feeding programs, including partnerships and collaboration between the public and private sectors to promote innovative systems in rural or remote areas and other high-risk areas where participation has been historically low. Strengthening and expanding the reach of the successful fresh fruits and vegetable program for elementary students from economically disadvantaged families to support a reduction in diabetes through improved dietary quality. And finally, further strengthening the WIC program by sustaining the evidence-based prescriptive WIC food package, expanding funding for breastfeeding peer counseling service, and investing in improvements to information systems and technology to better access and enroll in and better serve WIC participants and prevent diabetes. And that's the recommendation 9. If people have any questions or, again, concerns.
Yes, so it's Meredith Hawkins. Just a very quick question. Thank you. This has been a wonderful presentation. Quick question that a couple of times you used the terminology being undermined. Just wanted to clarify, was that purely on a budgetary basis, or were there any other factors that would have to be addressed?
So I wouldn't say it's undermined on a budgetary. I think there are always pressure to reduce standards. I think there was an effort. The USDA recently tried to reduce the nutrition standards in schools over the past couple of years, and it was overruled by a court this past April. So there's always sort of pressure to reduce the standards or lower the standards, and the argument is to help schools who are struggling to meet the standards, but our argument would be to give schools more help to implement the standards that are in place for a reason. And those standards were set after a great deal of debate and discussion among healthcare, nutrition, health policy experts, and nutritional experts to determine what the dietary guidelines should be. So our argument, I think, is support schools and give schools the resources that they need, whether it's funding, more additional funding to purchase fresh fruits and vegetables, as an example, and or the staff and money for training and the infrastructure they need, rather than just saying, well, the schools are having trouble, so let's lower the standards. Let's give the schools the resources they need through these programs, through these programs, to be able to implement the standards and give kids the nutritional, the types of foods that they need to make them healthy and help prevent chronic disease like diabetes. Does that help at all?
Yeah, thank you.
Sure. Well, I guess to reiterate, I think some of these are, we determined these are effective programs. Just the issue is that they need scaling up, and that is a policy decision. I wouldn't say that anybody's trying to undermine anything at the current funding levels, but we're arguing that these are programs have been shown effective through multiple studies, and that they should be ramped up so they can serve a larger larger number of kids across the country, and particularly kids who are in greatest needs and historically underserved communities and communities of color.
Aaron, this is Paul Conlon. May I ask a question about, I'm sorry, may I just ask a question about the second bullet, where at the end you said you're asking that the skills to run a program to effectively prevent diabetes be implemented. It's unclear what that means, and the reason I would be concerned, are you thinking, or could someone interpret that as they're going to be running a DPP in school systems? Or
sure.
Is this, so what was it that you were intending from that statement?
That's a great question, and I think that's on me for, I should probably maybe rewrite that a little bit, because I think what we're saying is skills to run the program, which again, in this case could be like the fresh fruits and vegetable programs or the school lunch programs. One of the concerns of the schools was that their staff were not trained to effectively implement these programs and get the healthy food to kids, and as a result, it prevents them from effectively implementing programs that help improve the kids' diets and help prevent chronic disease and prevent diabetes. So we kind of just said we went from the skills right to the diabetes, but really it's the skills to be able to implement these programs effectively and reach more kids and get more healthy food to kids. So that helps again instill good eating habits, healthy eating, and prevent chronic disease, and the major one being diabetes. Does that help? I could certainly rewrite that.
Yeah, thanks for the clarification.
Thanks for pointing that out.
Yeah.
Of course.
Naomi?
Hi, Aaron. Yes, thank you.
Hi, Naomi.
Hi, this is Naomi Fukugawa. I think these are great
specific recommendations, but I sensed or synthesized from it that there is a higher level recommendation to be coming with respect to potentially transforming our food system, at least in terms of our production, choice of production, and knowing how to, choices of foods that we produce, rather than maybe calling them all specialty crops. So will there be a planned broader recommendation to, in a sense, transform the food system a bit more? Because we do have to incentivize, some of the producers also. And so finding a way to impact rather than specific programs, but higher up.
Yes, and I think that's a really great point. And I think to that extent, we would go back to recommendation 7, and we can definitely wrap some of these up into a broader recommendation. But in regards to what you're saying in terms of changing the system and how we produce foods and what foods we produce and incentivizing the production, I think that goes back to our recommendation 7 in terms of giving greater incentives or support for farmers or producers of, again, they're called specialty crops, again, I think because these, unlike the other crops such as corn and wheat, they are more expensive to produce, and the profit margin is not as great because it's more money, just a lot of different things factoring into the fact that these are not as profitable. Therefore, it's not as big as a market. But that's where I think where the government needs to step in if we view this as a market failure, because it's not addressing public health needs. And I think we say that in here, but we could say it more maybe strongly, or we can highlight it in a larger recommendation that kind of combines some of those more specific ones. Does that make sense? Or Dean, does that seem reasonable?
Yeah, no, I wanted to comment. I think it's a great recommendation to have these recommendations, as well as the ones related to the fresh fruits and vegetable incentive in the SNAP program, which will increase the demand from the food system for healthier foods, to be included in an overarching recommendation. I think, though, Naomi, what you're also suggesting, which we'd like to take you up on as a member of the subcommittee, is are there specific additional recommendations that we can come up with that would help move forward a change in the food system? And so in preparation for our next presentation, perhaps we could dig deeper in what are additional levers, whether they're USDA levers or other levers, that we could make recommendations around to help catalyze a change in the food system. So it's a yes and a request for more discussion.
I agree with that. Thanks, Dave. Any other questions or concerns? And any of the recommendations?
Thanks, Aaron, very much.
Sure, thank you.
I'm going to turn now to Dr. Bill Herman, who will describe the background for draft recommendations numbers 10 and 11.
Great. Thank you, Dean. As Dean already mentioned, there have been 2 recommendations related to sugar-sweetened beverages. First, that sugar-sweetened beverages be eliminated from the SNAP benefit, and also that front-of-package added sugar labeling be applied to sugar-sweetened beverages with the added sugar expressed in teaspoons of added sugar. Recommendations 10 and 11 also relate to sugar-sweetened beverages. And by way of background, sugar-sweetened beverages comprise the largest single source of added sugar in the U.S. diet, probably 30 to 40% of added sugar. Intake levels are highest among younger people, lower SES groups, and among non-Hispanic blacks and Hispanics. Sugar-sweetened beverage consumption is associated with type 2 diabetes, cardiovascular disease, and all-cause mortality, and evidence suggests a causal relationship between sugar-sweetened beverage consumption and these conditions. It's been estimated that at least 9% of diabetes in the U.S. is attributable to sugar-sweetened beverage consumption, and that sugar-sweetened beverage consumption is a significant contributor to diabetes disparities. It's also been shown that increasing the price of sugar-sweetened beverages with an excise tax of about 1 cent per ounce, or about 10% to the price of a sugar-sweetened beverage, can reduce consumption by at least 10 to 20% and raise significant revenue to fund health promotion activities. And the health and economic benefits of these taxes are substantial. To date, 7 cities in the U.S. and about 40 countries have levied excise taxes on sugar-sweetened beverage, though at the same time, the American Beverage Association has succeeded in lobbying for states to pass preemptive legislation barring sugar-sweetened beverage taxation. So our first recommendation is that, as has been done with the federal tobacco tax, the U.S. Treasury impose an excise tax on sugar-sweetened beverages to cause at least a 10% increase in their shelf price. In addition, calculations regarding the amount of tax should employ a graded taxation model based on the amount of added sugar to stimulate reformulation of sugar-sweetened beverages by industry. And this is actually the policy that's been adopted in the UK. The tax applied to a sugar-sweetened beverage is related to the amount of sugar in the beverage. And the advantage of this is that there are thresholds, and a lot of the manufacturers have reduced the amount of sugar in the beverages to get below those various thresholds to reduce their tax burden and to preserve sales. So this seems to be an effective strategy to get sugar out of sugar-sweetened beverages. We also propose that the revenues generated by the sugar-sweetened beverage tax should be reinvested in a manner that promotes the health of those communities that bear a disproportionate burden of type 2 diabetes. And finally, that the Office of the U.S. Trade Representative should ensure that all international trade agreements allow for the taxation of sugar-sweetened beverages and for front-of-package health advisory labels. We're still exploring this last recommendation, but this is potentially a barrier to taxing and labeling that we need to address if these recommendations are to be implemented. The next slide shows a related recommendation. So if we can go on. Yeah. So in response to the evidence linking consumption of sugar-sweetened beverages to diabetes and cardiovascular disease, many organizations have recommended limiting intake of sugar-sweetened beverages. Previous attention is focused on restricting sugar-sweetened beverage sales in schools, with less attention paid to worksite bans. There is a recent study, however, of a workplace sugar-sweetened beverage sales ban in a health system that found that among employees who were frequent consumers, mean daily intake of sugar-sweetened beverages decreased by about 50% 10 months after the ban was implemented, and reductions in sugar-sweetened beverage intake correlated with improvements in waist circumference and insulin sensitivity. And the intervention was also found to be cost-saving to the employer. So our recommendation here is that policies should be adopted across federal agencies to prohibit the sale of sugar-sweetened beverages in federal government-owned or leased offices, workplaces, healthcare facilities, and public spaces, and that federal agencies should ensure on-site access to safe, clean water and healthy beverage alternatives. So these are the two recommendations related to sugar-sweetened beverages. Any comments or questions on those?
This is Ann Albright. some of the agencies, I can certainly speak for our campus at CDC, already has some of those restrictions. I'm not sure if it's certainly the evidence is very much in the sugar sweetened beverage lane, but wondered if there was any thought about pursuing sort of vending machine offerings in addition.
Yeah, I think our intent was to include that in prohibition of sales through federal government-owned or leased office spaces. So yes. So Anne, are you saying that there are restrictions within food service facilities, but not vending machines currently?
Well, it depends on the agency. It depends on what policies they have set for themselves. So, of course, at CDC, I can say in our building because we're the Chronic Disease Prevention and Health Promotion Center. So we try to practice what we teach. So we have now healthy food options in our vending, as well as no sale of sugar-sweetened beverages, at least sodas and those kinds of things. I'd have to double check on whether there's any sports beverages in there, but there are oftentimes vending machines with beverages, and then there are often separate vending machines with food options in them. They don't often exist in the same vending machine.
Yeah, so I think we would want to include that, though, and we can add that to the recommendation.
Are you suggesting to include regulate the content of vending machines in addition to the prohibition of sugar-sweetened beverage sales, Bill and Ann? What exactly was the point? I mean, because there are many points embedded in the larger point.
Well, my interpretation is if you're banning sugar-sweetened beverage sales, that would include sales from restaurants or snack bars, but also from vending machines in federal facilities.
Exactly.
Yes.
Yeah.
But I think, Ann, were you making another point about healthy alternatives in the vending machine?
Yeah, I just wondered if the group had considered, in addition to, I first wanted to reaffirm Bill's point because they can be sold in multiple locations. We have, federal buildings have contracts with food vendors, some of which I know our vendors are ones that support people with particular disabilities. But yes, my other point was, if the group has considered, and of course there's lots of options that can be made in those vending machines, the evidence may not be as clear to make that kind of statement or recommendation, but just that there is also food options sold in separate vending machines, whether or not you also went for the foods served in the cafeterias or restaurants, which would be more difficult, but potentially could be done in vending machines, and just wondered if the group had considered that yet, was really my question, or would be considering now.
At this point, I think we're limiting the recommendation to sugar-sweetened beverages, which would be sports drinks, sodas, and sweetened fruit juices, but we had not taken on other products in vending machines.
Thanks.
Hi, Dr. Herman, Bill Chong. I have a question. I was wondering if you could expand a little bit on when you refer to public spaces, sort of how expansive are you intending or thinking about in terms of the recommendation that you have up here in terms of the sale of sugar-sweetened beverages?
So we were trying to be all-inclusive. So public spaces might be national parks or those sorts of facilities as well.
And then just as a follow-up on that piece of it, so for this prohibition that you're proposing, is this in terms of food vendors contracted through the park service, or in terms of other, I guess I'm just wondering, for instance, down on the National Mall, there are sort of private vendors who park and take up space to sell food and beverages to tourists who come through. Is the intention then that those private vendors would also be prohibited from selling sugar-sweetened beverages, or is it more sort of in the context of for example, at the food contractor who provides food at the cafeteria in the museum. I'm just trying to kind of get a better grasp of sort of like what sort of extent you guys were thinking of with this recommendation.
Yeah, those are useful comments. I think we were trying to be as all-inclusive as we could. If there's a food truck parked on the public street next to the National Mall, then I'm not sure how we would handle that, but certainly, yeah, so I think those are details that we'll need to work out and think about the practicality of the recommendation as well.
I would comment that in the study that Dr. Herman quoted, which was a large, it was a UC health system study, it involved products sold by the university as part of its cafeteria services and all the vendors on the university campuses. So that would include everything from a Subway, to a vending machine, to a local truck that is parked on the university campus. All of those vendors and contractors were subject to the prohibition. Of note, in the cost effectiveness analysis, the lost revenue to the university and to vendors was taken into account in that regard. So there was a small reduction in revenue related to a drop in sugar-sweetened beverage sales that was only partially made up by an increase in the sales of healthier beverages. But the cost offset with respect to health insurance costs, particularly dental costs, more than offset those losses.
Thank you. This is Bill Chong again. I have one additional question with regards to, I think, your prior recommendation about the excise tax. I'm not completely familiar with this, but this sounds similar to what I think they're implementing in New York City, where they're adding a sales tax on sugar-sweetened beverages. I'm just wondering, do we know from that effort if there's been, if they've seen benefits within the New York City population, or if it's perhaps too early to see if there's any sort of effect from the addition of the tax?
Yeah, no, there are good data from a number of the city excise taxes in Philadelphia and I believe Seattle and Berkeley as well that have suggested decreased consumption, substitution of healthier beverages, and positive revenues. I don't believe that the tax went through in New York City, so I think that there was a problem there. And rather than a sales tax, it is important. We specified an excise tax because it is important that the price be seen on the shelf or, as the individual picks up the sugar-sweetened beverage, not that it be added at the checkout, because we really want people to be aware of the price that they're paying for it. So again, that's why we've specified an excise tax.
Great, thank you. I think that makes complete sense that you want the consumer to see it at the point of purchase where they can identify when they're making their decision. That does make sense. It's reassuring to hear that at least in some of the cities where they've pursued some similar sorts of approaches, that they're starting to see some benefits from that.
And the analyses have been quite sophisticated, looking to see then if outside of the city of Philadelphia, sugar-sweetened beverage sales increase, and the data have been reassuring that it really is reducing consumption. So Dean, turn it back over to you.
Thank you, Bill. Thank you for the questions and comments. I'm going to move to draft recommendation 12 that I will present. The background is the fact that the social environmental context for many is diabetogenic, leaves clinicians and patients often unsupported or left to their own devices in their attempts to prevent and control diabetes. This is certainly true when we are enrolling someone in the national DPP or when we are trying to engage them in successful self-management of their diabetes through physical activity and stress reduction. So to prevent and control type 2 diabetes and to reduce disparities, significant changes need to take place in the social and environmental context in which we live, learn, work, and play. But fostering such change cannot be left only to those federal agencies that are accountable to healthcare concerns. CMS has very little control over the social and environmental context, for example, in which we live. So effective strategies can only be implemented by those federal agencies considered to be non-health focused, but that do help shape the social and environmental context that heavily influence incidence and complications of diabetes. These agencies include domains such as food and agriculture, trade and commerce, transport, housing, and education. As a subcommittee, we explored whether the U.S. government, in fact, has the appropriate structures, policies, and practices in place to enable this kind of trans-agency strategic planning and to facilitate trans-agency action around type 2 diabetes. And we learned that while most developed nations are affirmatively addressing type 2 diabetes through transsectoral governmental entities and associated activities, the United States, which has one of the highest rates of diabetes in the world, is severely lagging in this regard. Specifically, the U.S. has no entity to enable trans-agency collaboration to prevent and control type 2 diabetes, and as a result, the U.S. engages in little to no transsectoral work. What little work has been done, and that work has been done in part with the leadership of the CDC, has generally been of a pilot nature and has lacked the ability to scale. This really represents an untapped opportunity to better leverage the efforts of multiple federal agencies and to increase coordination between them to achieve the outcomes called for in the NCCC Charter. So our recommendation is that a new federal entity be created to foster broad trans-agency collaborative work aimed at positively changing the social and environmental contexts that are promoting the type 2 diabetes epidemic. In addition to involving departments and agencies within Department of Health and Human Services, this entity should include, but not be limited to, a Department of Agriculture, Transportation, Education, etc., the Federal Trade Commission, the EPA, and the Bureau of Indian Affairs. We recommend that this entity would have as primary responsibilities to facilitate coordination among federal agencies with respect to trans-agency approaches to preventing and controlling type 2 diabetes. I specifically want to mention we're focusing on trans-agency approaches, and then make recommendations to the executive and legislative branches regarding actions they can take to prevent and control type 2 diabetes. We recommend preliminarily, and this requires further discussion, that this entity be positioned at a secretarial level, potentially at the level of the Secretary of Health and Human Services. Now, we will note that for a 5-year period of time, this type of entity was in existence in the United States, and it achieved its preliminary objectives quite successfully. Known in brief as the National Prevention Council, it was comprised of 20 federal agencies, included those listed above, and it was chaired by the Surgeon General. And as I said, it had similar objectives, and I believe it was located in the Secretary of Health and Human Services office. So this is something that has been done before, but this council, which had overall health as its goal, not specific to diabetes, it was terminated in 2016. So I will open it up there for comments and questions and concerns.
Hi, Dean. This is Sherry. Do you know why it was stopped? I mean, was it found not to be very effective? Was it some other constraint?
Perhaps somebody from the CDC, Ann, might be able to comment. My understanding, which is not even secondhand but thirdhand, was that it was associated with the administration change. The National Prevention Council was a line item, if you will, in the Affordable Care Act. There were funds dedicated to a number of prevention activities throughout the country, including the National Prevention Council. So I believe it was felt to be a fairly politicized part of the, by virtue of being linked to the Affordable Care Act. In addition, my understanding is insignificant or inadequate cases were made as to how prevention at a national level in this way could lead to cost savings across the federal government, so as to make it have a more bipartisan appeal. but that's again third-hand interpretation. Ann Albright may have a first-hand account of what happened there.
I don't have any additional information. There were a number of things that were examined, as happens when any new administration comes in, and we're asked to look at a number of things, and a number of things are reviewed by entities who make sort of recommendations to the new administration. So it certainly could have, but I have no further detail.
Do you have a sense, Anne, with the other part of Sherry's question was it felt to have been an ineffective council, or was there a sense that it was doing good work, or?
I'm not sure. I have not heard what has come of that council or what recommendations they made and what came of them. Certainly we can try to find out, find people who served on it, and if they had any thoughts about it. I don't know, Dean, if you connected with Ruth Peterson and whether she or her team were a part of that group, because they would certainly be the ones I would think of in our center who would likely be on it.
Yes, we have that lined up as one of our key informant interviews coming up, is to identify someone who is in the leadership capacity. These actually were the cabinet level posted people who were represented on the council, and obviously they probably sent delegates, but we will find them and interview them.
Yeah, and Ruth may be able to give more insight into how best to do that.
Thank you. Do you have specific thoughts, Anne, on, obviously, this is meant to complement the efforts of the DDT. Do you have any thoughts on how this body could function in a way that would be supplemental to the CDC's efforts and supportive of those efforts?
Well, I think like any of these bodies that we're talking about, our group mentioned one as well, and certainly our colleagues in the treatment complications, they also, I think there is a bit of a line here that one has to navigate, a bit of a needle that has to be threaded here, because you certainly want to have what our ultimate goal is which is certainly effective collaboration and coordination across the agencies who work in the diabetes and related areas. And each agency has its mission, they have their charge, they have their legal authority, and they also have to contend with a lot of getting things through clearance, getting things reviewed by any number of people, most often getting things out for public comment, processing all those things, and then they have to execute the work. So there's no lack of oversight of things. Sometimes it's actually incredibly constraining, but I think it's a question of, is another body going to help facilitate that, going to help assure that outcome, or could it unfortunately be interpreted that it's another body who's now going to have to look at everything and determine whether something is a go or no go? That would absolutely paralyze the work of these agencies. So it's really going to be important that what wording this commission uses for any kind of body like this, that it doesn't end up with so much oversight, and unfortunately can be by people who don't actually have direct knowledge of the topic. It could be, again, some assignee or somebody who's asked to more or less administrate it. But, if you're asking somebody to make decisions about content area and they actually don't know the content area, those SMEs exist within the agencies. Those are just some of the very, very possible things that can happen that would, I think, not serve the goal.
The unintended consequences,
Yeah.
The unintended consequences.
And so the wording on any of these bodies is going to have to be very careful, as are the recommendations, so that they don't end up with a bunch of unfunded mandates to the agencies. Again, how they can come down to the specific entity within an agency who conducts this work. It can be difficult when you get language from Congress that itemizes so specifically that you are boxed in from allowing you to move on what new evidence allows you to embark on. If those recommendations or those requirements from congressional language are so specific and are so constraining that you are stuck with those until somebody in the legislative world decides to change them. And then you have to continue to do something that current evidence may be less, appropriate for you to be following.
Thank you.
Dean, you have about 10 minutes left.
Okay. I'm going to pass the baton to Dr. Bill Cook, who will talk about housing and diabetes.
Okay, thanks, Dean. So the background on this, homelessness and housing instability, as well as the quality and context of housing pose a risk for diabetes and significantly impair the ability to manage those who do have diabetes. The federal government currently influences housing through two of its agencies. One is HUD, which subsidizes housing via public authority-owned housing. That's over 2 million people across the country. And the Housing Voucher Program, which is about 5 million people, for privately owned subsidized housing, otherwise known as Section 8 housing. The IRS is also involved in this. They manage the low-income housing tax credit program, which gives tax credits to developers for low-income subsidized or mixed housing. Families that need to spend more than 30% of their income on housing have difficulty affording food and medicine and medical interventions. Data support the importance of housing for clinical outcomes. There was a massive randomized trial sponsored by HUD called Moving to Opportunity that demonstrated that moving from public housing in a high poverty zone to a low poverty zone is associated with lower diabetes incidence down the road. Smoking restrictions that are used in public housing have been shown to improve health. There have been programs like the Support and Services at Home, or SASH program in Vermont, that demonstrated better health outcomes with use of wellness nurses and care coordination in public housing in that state. However, despite this knowledge and these problems, fewer than 1 in 5 families that are eligible for a public or subsidized housing credit ever receive these services. So the recommendations that we came up with, the NCC recommends that in order to reduce type 2 diabetes incidence and diabetes complications and reduce costs to the government and to society, that HUD expand its federal housing assistance programs to allow access for more qualifying families, such that over a 20-year period, all that qualify can access subsidized or public housing. That the IRS further incentivize developers to place units into low poverty areas where it's been shown to be the most beneficial to prevent the development of obesity and diabetes. That the IRS integrate neighborhood health parameters into the Qualified Allocation Plan, or QAP, process and their scoring systems that goes into awarding these contracts to developers, or the credits in all the states using the tax credit program, leaving latitude for the states themselves to exercise some local control to allow for local conditions. These health parameters would include, but not be limited to, embedded or nearby healthcare services, transportation, employment opportunities, education opportunities, food availability, and healthy exercise and recreation activities being available. And also that HUD establish a means to fund or subsidize the cost of embedding health services if they're needed into developments, so as to incentivize committing space or employing unused space for such services in their plans. And that would also go for the housing tax credit program, which we probably need to add on to HUD. So those were our recommendations. Be happy to entertain any questions or comments. I guess if there are none, I'll turn it back over to Dean.
Thank you, Bill. I'm going to piggyback draft recommendation 14 onto yours, which still has to do with housing, but it's specific to secondhand smoke exposure. So the consumption or exposure to tobacco smoke elevates the risk of incident diabetes and amplifies the risk of complications, particularly macrovascular complications and death among people who have diabetes. We know that diabetes prevalence is nearly double that comparing people living in public housing to the general population. We also know that smoking rates and rates of exposure to secondhand smoke are even higher among people living with diabetes and prediabetes, especially among those who are poor, who have limited education, and who are Black, each of which more than doubles the odds of having secondhand smoke exposure or being a smoker. As such, socioeconomic and racial disparities in diabetes incidence, complications, and death, in part, particularly related to macrovascular disease, exist as a result of inequitable access to tobacco control interventions. Now, there is a very positive program that HUD implemented in 2018. To mitigate tobacco-related disparities, HUD implemented a mandatory smoke-free policy requiring that all public housing authority-owned housing prohibit combustible tobacco use in indoor dwelling and shared areas and in outdoor areas within 25 feet of exits and windows. However, this policy does not apply to multi-unit housing, including Section 8 federally subsidized housing, which comprises the majority of housing for beneficiaries, leaving these sites unprotected from secondhand smoke unless residents voluntarily make their apartments smoke-free. Studies, including those done by the CDC, have shown that African American children, for example, half of them have secondhand smoke exposure measurable in their blood in public housing sites. So we recommend, expanding HUD's smoke-free policy to federally subsidized housing units could have significant population-level benefits by reducing diabetes incidence, complications, and deaths. So our recommendation is quite straightforward, that in order to reduce type 2, particularly diabetes complications, that HUD broaden implementation of indoor smoke-free policies to include subsidized multi-unit housing beyond public housing authority-owned housing, and that HUD require multi-unit housing that are adopting smoke-free policies to also provide access to cessation resources, such as referrals to cessation helplines. Comments or questions?
This is Sherry. Just a quick question. Do they, is that under their ability at HUD to require provision of cessation resources? I just know that there's some differences state to state, even in the quit line and things like that. So I didn't know if that's even under their purview.
Yeah, so we have a query out to an expert with respect to what HUD's authority is with respect to public housing owned buildings versus those that are essentially contracted to serve people who have the housing voucher. We understand that HUD does have certain authority in this regard, but we do not have clarity yet on what specific language would need to be required to enable this recommendation to be feasible. I have learned that it is within their authority to do so, but I don't understand the state-to-state variation. There also are, getting back to Ann Albright's comments about unintended consequences, we have to consider the unintended consequences of what it might mean for an individual, either for the owner of the building to say, oh, this is too complicated, I'm going to get out of the business of then being a Section 8 housing landlord. That would be an unintended consequence, or the unintended consequence of someone who the landlord feels is an undesirable tenant to be evicted because they were smoking on the property. That would also be an unintended consequence that would not be good for people living with diabetes or at risk for diabetes. So this is, I would say, very much a draft recommendation for those particular reasons.
Hi, this is Ayatunde. Yeah, I have quite a bit of concern about that, actually, along the same lines of the unintended consequences that you've mentioned. One would hate to increase homelessness because of a recommendation related to diabetes prevention.
Exactly. Yeah, so my understanding is did you have an additional point, or were you just amplifying that concern?
Yeah, I'm trying to amplify that concern and think about that we need to give a lot of thought to that. I have major concerns about, there are people who are addicted to tobacco and therefore it may not be that easy to quit. And therefore, I would hate for them to lose their housing because of that, which the implications or the downside of it is much worse than risk of developing diabetes.
Right. So what I think we need to do is to understand with respect to the 2018 change in regulations in Public Housing Authority, what have we learned with respect to what happens to individuals and families if they are found to repeatedly be in violation of HUD policy, and understand the impact that has on the risk of homelessness, and what mitigating options are available to individuals to prevent eviction or relocation.
Yeah, it would also be nice to understand whether HUD could actually provide or how much support is there for people who might be in that situation to be able to quit smoking.
Under the current regulations.
Yes, that currently exists. Yeah.
Yes. Thank you. We will take those into consideration and see this recommendation as a draft recommendation at this point.
Dean, this is Paul Conlon. One compromise would be to have the recommendation be that smoke-free environments be in all common areas of multi-dwelling housing units. If one assumes that one's home is one's castle, it may be more difficult to limit it in that environment with consequences, other than maybe cleaning or other security deposits but it wouldn't be too far of a reach to say that any common areas or immediately surrounding areas of the building would be smoke-free.
Thanks.
So I would agree with that. To say something again, I think that is a far more, you don't lose your housing, but at least you don't necessarily expose other people to secondhand smoke because of the smoking habit. I think I'm far more comfortable with that, and I think that could still have significant impact generally in those kind of housing.
Thank you. Let me close our section here just to briefly say the next steps. We're awaiting the synthesis of the literature search, and we'll refine and finalize these 14 recommendations that we presented over the last 2 meetings. We are planning to conduct a further literature search on the other non-health domains that I've listed here, and conduct a small set of additional interviews with key informants, including the FTC regarding marketing to children, the EPA regarding fresh water and pollution, those who served on the prior Prevention Council, and experts in child care, and compose new draft recommendations in these domains. Thank you very much.
Great. Thank you very much, Dean, and thanks to the Prevention General Population Subcommittee for this update. We're running behind now, but I think we can catch up. I do want to go on to the oral public comments at 4:55. I was going to have a quick discussion on access to care and system-level interventions to improve the delivery of care. As you all recall, this was a work group that we talked about at our September meeting, and I just wanted to say a few more words about it now. One of the unspoken assumptions that we've made is that people with diabetes and those at risk for diabetes have access to health care. And we all know that this isn't always the case. And so I do think as a commission we need to make some recommendations related to access to health care. In 2009, the National Academy of Sciences pointed out that access to health care is critical to successful birth outcomes, reducing the incidence of preventable diseases, the early detection and diagnosis of treatable diseases, reducing the effects of chronic diseases, and prolonging life and reducing morbidity through timely and appropriate treatment. And all of these are obviously goals that our commission is addressing. Next slide, please. We also recognize that access to care depends on, to a large degree, insurance coverage, but also having enough providers and hospitals to deliver care, and an individual's capacity to make appropriate use of available healthcare resources, largely related to health literacy. Next slide, please. One of the problems that we need to address is that in the United States, the health insurance system is pluralistic. The foundation is employer-based health coverage, though Medicare, Medicaid, and state-level exchanges and federal marketplaces also play an important role. And I think we need to think systematically about addressing gaps in these programs, particularly the federal programs, Medicare, Medicaid, and the exchanges and marketplace, to ensure that people have access to care. So what this work group is attempting to do is to provide recommendations to departments and agencies, primarily to expand access to care and the affordability of care, but also paying some attention to further implementation of successful models for integrated service delivery and payment. So since the September meeting, we've narrowed the scope of what we're trying to do with this work group. We're currently scheduling a number of key informant calls. And once again, I'd like to invite any of the NCCC members to participate in these calls and to participate in the work group deliberations. So we're going to have some calls set up beginning next week. We will send them out to everyone. And if anyone is at all interested in being involved in this work group, I again recognize your contributions to the subcommittees and your current heavy plates in terms of what you're working on. But we would certainly welcome input to this work group. So that was all I wanted to say on this topic. Are there any questions, comments, concerns?
Bill, this is Dean.
Sure.
Again, my gratitude for for taking this on. Have you decided if the second bullet point is going to continue to be in play, or is it primarily the first bullet point?
So I think the first bullet point is going to be our major focus as they relate to Medicare, Medicaid, and the marketplace. Some of the issues in terms of team care and some of the various models of care have been discussed and taken up by the Treatment and Complications Subcommittee, for instance. But if there are topics that have not been addressed, we want to at least look at them systematically and potentially make some recommendations.
Yeah, I guess my only thought is, to further bring alignment to the recommendations that our subcommittee is coming up with and those that the two others are coming up with, that one can imagine that the model of an accountable care organization makes it all make sense, right? Whether you have sugar-sweetened beverages in the workplace, or whether they cost more money, or whether you have housing for your beneficiaries, all of those things in an accountable care organization are meaningful because of their relationship to health. Whereas in a fee-for-service model, it's an externality. So on the other hand, I appreciate the challenge that reviewing models of integrated service delivery and payment would pose to a new subcommittee. So I don't understate that. Don't mean to understate that, but.
So I think our focus is going to be on what the Center for Medicare and Medicaid Services Innovation Center has focused on, and being sure that any successful models are pulled out and discussed across the various subcommittees along the lines that you indicated.
Thank you.
Good. Okay. We're on now to oral public comments, and we have 9 individuals who have requested time to comment. Are they, Clydette, are folks queued up and ready to go?
Hi, this is Mary Hearns Ayodele. I'm ready to go.
Yeah, Bill, this is Jennifer. So if you go ahead and announce their name, we'll start with the time that they have. And if they are on the line, they can go ahead and speak.
Okay, Mary, we're going to put you on hold for a second and start with Shirley McKellar. If Shirley is on, this is your opportunity to speak. Shirley McKellar. And there's no technical, do we know if she is on the line?
We don't know if she is on the line, Bill.
Okay. The next person we have is Rakesh Rajput. Is Rakesh on the line? All right. How about Adrienne Shapiro? Is Adrienne on the line? All right. Next we have Jacinta Voma. And we're sure there's not a technical problem.
Yep, I'm very sure.
Okay. Next we have Margaret Evans. No. Next, Abdel Jalil Makawi. Next, Baha Hadi. Mary, my apologies, we are up to you. So this is Mary Hearns Ayodele.
Ayodele, thank you, sir. Thank you, everyone, for allowing. Thank you. I appreciate the public comments. Thank you for inviting us to speak. I will be brief. I am a public school teacher in Texas, as well as a member of the faith community here and a leader within it. I walk the line between immigrant African faith communities and African American faith communities. And the topic of this call, this meeting number 9, is really dear to us on all levels. Those of us who are aware of what our children in public schools are being fed. The prevention model that was discussed in this meeting today is really important and helpful to all of us, because a lot of what we see in public schools are free food, but the quality of the food may not be helpful in the long-term effects on health, such as powdered donuts for breakfast and Coca-Cola and things like that. And even though the prevention portion of this meeting didn't get into specific details, I want to say that this meeting is really important to people who are struggling to make ends meet and may be in areas where they don't have access to fresh food, fresh vegetables, I should say, and fruit or high quality foods. So I will be taking the recommendations back to my communities that I heard in this meeting today, and I will be letting them know that the federal government does care about our health and that there are new recommendations or enhanced ones coming down the line for prevention, and unfortunately for people who've already contracted diabetes and other metabolic diseases like that. There are some ideas about how the health insurance situation, which is very complex and sometimes out of reach for many of the people that I work with, that there are some recommendations coming along where people who don't have access to preventive care or people who are just really wanting to know how to prevent this from happening to them and their families, there's some good recommendations coming out and there's some help coming along. So I'm going to be on the mailing list. I'm going to participate in as many meetings as I can, and I will be sure and take this information back to the communities that I serve and that I'm a part of. So thank you.
Thank you very much for those comments. Next, we have Alice Johnson Morton. No, and are any of the public commenters who we've skipped over on the line now, and would you like to speak? So speak up now if you're on. All right, so I think that's all of the public comment at this point. I'll turn it over to Clydette Powell now for an update on public comment solicitation.
Thank you, Bill. As you have seen and heard today, the National Clinical Care Commission and its 3 subcommittees have been working on many draft recommendations that will form the core of the final report to Congress and to the Secretary of Health and Human Services. This is a report that will be due in October of 2021. This process of draft recommendations entails much background work at the subcommittee level, as you have seen today, looking at current federal diabetes programs and relevant subtopic areas. This has been done through a large federal data call, as well as exploring the evidence base in the scientific literature and conducting extensive calls with stakeholders. Following this meeting, the Office on Women's Health and the Office of Disease Prevention and Health Promotion, in conjunction with our contractors, will set up a mechanism and start a process to solicit public comments on these draft recommendations. The solicitation of public comments and stakeholder input will help the National Clinical Care Commission shape and strengthen their draft recommendations. Now, as you see on this slide, in general, there have been 3 means by which the public can provide comments and inputs to the National Clinical Care Commission. There are the traditional oral public comment periods of 3 minutes at each per person at each full commission meeting. There is also an email inbox that can receive comments at any time. And we've also used in the past a Federal Register notice and regulations.gov. This was done earlier this year as a 2 to 3 month window for comments on overarching issues that were being considered by the Commission. What we're now planning is to have an open, continuous, over 6 to 7 months window of time for ongoing public comments on the draft recommendations, sometime between the end of this year and June of next year. This will allow an iterative process that will assist the subcommittees and the Commission leading up to the full Commission meeting in February and June of next year, and then its final approval of the report in September. On slide 2, we have a schematic of this process. We will be today, as you've seen, the subcommittees are presenting, discussing, approving draft recommendations. We will not post anything until a subcommittee has agreed to that version of their draft recommendation. The Office on Women's Health is in the process of drafting memos and a Federal Register notice that will be posted by the Office of Federal Register Notices. And then that will be, the public will be able to read and submit comments and documents on regulations.gov. We are currently exploring using the platform of health.gov, where we already post information about the Commission, members, meeting dates, minutes, recordings, etc., and to include there information on the Federal Register notice so that the public can be made aware that there are draft recommendations for which we solicit their comments. Internally, we will be using a federal docket management system to manage all those comments that come through regulations.gov. And then the Office on Women's Health, working in conjunction with our contractor and subcontractor, will organize those comments and provide input on a periodic basis to the subcommittees so that they can hear and read what the public is saying about those draft recommendations. This, in essence, is the process. As I mentioned, we are just exploring this now, likely to use the health.gov as our platform, and we will keep the public apprised of that. We will amplify those messages using listservs, tweets, and other social media in order to let the public know that we would like their input. So stay tuned, and that concludes my remarks. Thank you.
Thank you, Clydette. Are there plans to actually make, for instance, our key informants aware that these draft recommendations are posted for comment? I'm not sure how often folks actually access the Federal Register or the regulations.gov. So I think there might be some value in terms of, you mentioned listservs, but reaching out to people who have provided input or who have expressed an interest in the activities of the commission. Is that envisioned at all?
Yes, that's correct, Bill. That's why I mentioned that we would be amplifying this message. We will be discussing with our contractor and subcontractor the best ways of doing it. Now that we have both the Office on Women's Health, which has a broader net of distribution of communications, working in conjunction with the Office of Disease Prevention and Health Promotion and their communications division, and working with our contractor, we hope that we'll get the message out frequently. The idea is to have an ongoing iterative process of public input and public comments that will help the subcommittees reshape their draft recommendations. So at the mid-February meeting, we will have some better sense of how actively engaged the public has been in commenting on these draft recommendations that they have heard today.
And will we be reaching out then to the subcommittee chairs to determine which draft recommendations they would like to post? Will we do that periodically? How will that process work?
Yes, that's an excellent question, Bill. We really see this process as being driven by the subcommittees, their co-chairs, and ultimately the full commission and you as chair. We only want to post what the subcommittees have agreed that they want posted and for which they would want comments. We'll do a lot of work behind the scenes to organize this, given that there are quite a number of recommendations, and we're hoping that we'll be a number of people in the public and various stakeholders who will want to comment on them.
And I guess I would view this as an opportunity to get public input. So I would encourage the subcommittees and the subcommittee chairs to potentially submit draft recommendations that they want comments on, not feeling that they're final, but that they would like help perhaps reshaping them or thinking through all of the implications.
Exactly, and we'll be working further with the co-chairs at the next co-chair meeting to detail this.
Good. Thanks, Clydette. Are there any other comments on this then from any of the commission members? Okay, great. The next agenda item is recognition and appreciation of services to the National Clinical Care Commission. And I want to recognize two members of the commission who have left or will be leaving the commission soon. The first is Dr. Ann Albright, who will be retiring at the end of December as director of CDC's Division of Diabetes Translation. And the second is Captain David Wong, who is a medical officer in the Office of Minority Health, who has been detailed to focus on the COVID-19 pandemic. I want to thank both of them on behalf of the National Clinical Care Commission for their dedication and contributions to the work of the Commission, and let them know that we are preparing certificates of appreciation for them that they'll be receiving shortly. So Anne and David, we thank you both very much for your service, and we'll certainly miss you from the Commission.
Thanks a lot, Bill, and thanks to all of you. It's such a pleasure working with you, and I'll continue to help in whatever way I can. Appreciate all the work everyone's doing. I'll miss all of you.
Good, and I think we'll probably be reaching out to you in your unofficial capacity as well, but thank you very much.
Thank you, Anne. We love you. Thank you.
Thanks. Same. I love you guys too.
Great. meeting review and next steps is our final agenda item. I think we've had, again, a very productive meeting. I think these meetings do stimulate a lot of discussion and progress in the subcommittees. I would like to see us keep this level of activity moving forward even over the upcoming holidays, and would encourage the subcommittees to continue to meet and to have deliberations. I think drafting the recommendations and kicking them around among the members of the subcommittees is an excellent process, and would perhaps encourage you to do that at least once between now and the next full commission meeting. As I mentioned as well, we will be having some key informant calls for the focusing on access to care. We'll be sure that everyone sees those invitations. And if anyone would like to volunteer to join that work group on a regular basis, I would certainly appreciate that as well. Clydette, do you have any final comments or closing remarks?
Thank you, Bill. I have so much excitement about the work of the dedication and the work of this commission, and it has been an excellent afternoon to see how that is reflected in the presentations that we've heard from the three subcommittees. I don't have other further comments other than we will be regrouping as a full commission on February 17th of next year. However, between now and then, there will be a lot of activity, the holidays notwithstanding, to stand up the public comment section, as well as to help the subcommittees and co-chairs decide how best they would like that. So with this last comment, I will adjourn the meeting.
Clydette? Wait,
Yes.
Clydette, before we start, sorry, I had one last comment and question. This is Dean, if I could.
Please go
Right
ahead.
ahead.
Yes.
Sure.
So I realized that I failed to raise one issue with the treatment and complications group that I wanted to make sure I raised, because it's been a blind spot, certainly in the work I've done, which is in the workforce and in the team-based model, it might be worthwhile to highlight the role of oral health providers. So just something to think about, given the relationship between diabetes and poor oral health, and the relationship between poor oral health and diabetes. And then second, in terms of the February meeting, I wanted to get some clarification perhaps from Bill and Clydette for all of us in our subcommittees as to whether, is that the meeting at which point we should be presenting our quote-unquote final draft recommendations, or what is the time frame for when we have our final set for us all to consider as a larger group?
Yeah, thank you, Dean. Comments and questions. Bill, did you want to answer that, or would you like me to take it?
Go ahead, Clydette.
Yes, as you know, we had our round one of recommendations in September. This is round two. In February, it will be round three. We expect that there will continue to be some adjusting of recommendations, some further discussion between February and June. We would hope that by June of next year, the Commission would have pretty much settled on the recommendations that they want to put forward, coupled with their background information, the rationale, the scientific basis for those, and then use the summer to pull together that report such that by September of next year, the Commission would be meeting in order to review for the last time and approve final report. So I would say that recommendations, although they round 1, 2, and 3, we anticipate that the Commission would have settled on their recommendations by that June meeting.
By June. Okay, thank you.
Yeah, and Dean, I think the way the General Population Subcommittee summarized the earlier recommendations and then focused on the new recommendations was quite effective, and I would encourage each of the subcommittees to do that for the February meeting. I think our time is finite, and as we carry more recommendations forward, I think the fine tinkering with them can be done behind the scenes and just summarize where we are with the previous recommendations, but focus February and June are going to be the only opportunities, I think, to really bring forward new recommendations for discussion. So I'd like to focus on them at those two meetings. Good. Any other comments or discussion? Claudette?
Yes, I will just mention that February meeting will be another virtual meeting. We have not yet decided what the June meeting and September meetings will look like. So we will plan on a similar kind of format and timing and duration as we did for this meeting today. It seems that there are no other comments or questions, so I will call this meeting as adjourned. Thank you.